Hello, everyone. My name is Peppermint, and welcome to the second annual Black Queer Town Hall in STEM and Healthcare. This two-day event is designed to highlight the strength, power, and resilience of Black queer scientists. Our program is made possible by the generous support of Ginkgo Bioworks, the University of Pennsylvania, the University of Iowa, and Boston Medical Center. The first day of this town hall is focused on medicine and healthcare. Day one will feature two panel discussions on topics related to Black queer health and combating the anti-transgender movement, as well as a keynote from a clinician scientist who focuses on sexual health and gender minority health for people of color. The second day is focused on basic science and the impact of diversity, equity, and inclusion work in the academy, and will feature a flash talk competition between scientists at the trainee and early career level charged with sharing how their work pertains to your everyday life, because it do pertain. So, this first panel is focused on discussing major challenges to equitable healthcare for the Black queer community and envisioning solutions that will drive us toward intersectional health justice. This panel features an all-star lineup of two psychologists, a physician advocate, and health equity scientists who discuss the complex relationships between systemic discrimination and health for Black queer people, while also highlighting the unique strengths of our population. Please enjoy.
Good evening. My name is Kemji Nwiki, and I'm a second-year med student at St. George's University. I'm so excited to welcome you guys to the Black Queer Town Hall this evening. We have a fantastic panel of experts here to answer questions that have been submitted by our audience to hopefully stimulate a discussion and hopefully show you guys some of the work that they are doing in the community and also ways that you guys can get involved. So before we start the questions, I just hope that every panelist can introduce themselves with their name and their pronouns and a little bit about your work.
I can dive in first. So I'm Dr. L. Lett, and I'd like to start with I'm a Black transgender woman. I think that statement about who I am and that positionality statement is core to the work that I do. And so I'm a statistician, epidemiologist, and physician in training. And what I do can all really be summed up in taking the populations that are kind of relegated to the margins of health equity and health services provisions and bringing them to the center and being the focus of my scholarship. And I do that by applying the principles and theories of Black feminism to rigorous epidemiological work and really transdisciplinary work. And so what that means is that I study how Black queer people and how other oppressed groups move through the world and try to identify how our strengths can be the tools to our liberation. And that's really me. I'm at the University of Pennsylvania, where I'm finishing up my medical training, and I'm also affiliated with Boston Children's Hospital Computational Health Informatics Program, where I'm doing some work on algorithmic fairness and justice. And with that, I'll pass it to one of the other panelists.
Dr. Blackstone?
Sure. Hi, everyone. It's really an honor to be here. I'm really grateful to be able to be in conversation with all of you today. I am my pronouns are she, her, hers. I am a primary care and HIV physician in New York City. I'm also founder and executive director of Health Justice, which is a racial and health equity consulting firm. And I work with public health and healthcare organizations to support them in centering anti-racism, equity in the workplace, and reducing inequities in the communities that they serve. I also had a previous career in academic research, so I did a lot of research around HIV engagement and prevention, in particular focused on cisgender women, and then also including trans women as well. And also led the Bureau of HIV at the New York City Health Department for several years before starting my business. So I have a lot of different hats, and it's just really an honor and a pleasure to be here. And thank you again for the invitation, Elle.
Thank you so much. Dr. Lassiter?
Hello, everyone. So thank you so much for this invitation. I'm so happy to have this conversation. So my name is Dr. Jonathan Matthias Lassiter. My pronouns are he, him, his. And I always like to say I am the grandson of a sharecropper and the son of a pest control business owner. And within a generation, I was able to be the first person in my family to get a PhD, and I'm very happy about that. And so everywhere I go, Lassiter, my ancestors' names, gets into that room, and they say, have to call me doctor. And so I know my grandfather would be very proud because he never even imagined that for himself or his children. So who am I? I am a Black, same gender loving psychologist. I am Black and same gender loving first, psychologist second. So all the work that I do is through that lens. And so I have a private practice through Lassiter Health Initiatives, and I do some educational training around Afrocentric psychology. I am an artistic associate at Black Acting Method Studio, where I help Black actors learn how to fortify their mental health in a very racist field. And I am an assistant professor, I like to call it my day job, at Rowan University in Southern New Jersey. My work is influenced, as I said, by Afrocentric psychology. So really grounding my work in African-centered values. I always tell my students, what you're learning is Eurocentric psychology. They don't call it that, but that's what you're learning. So I like to turn that on its head and center the African-centered values in that, along with intersectionality, health equity, and Black LGBTQ health. So I'm looking forward to this conversation, but I'm going to be quiet right now.
Thank you so much for your introduction, Dr. Lassiter. And now we have Dr. Jackson.
Yeah. Hey, everybody. It is such a pleasure to be here for today's discussion. I am Skylar Jackson. I use he, him pronouns, and I am a psychologist by training, but today wear a number of different hats in addition to that. So I'm also a researcher and do quite a bit of consulting work on what is increasingly called DEI work. I'll talk a little bit about my institutional affiliation. Despite being a psychologist, I'm now housed within a school of public health, where I'm doing a lot of interdisciplinary work to try to solve some of the issues we see around stigma and marginalized populations. So at my heart, I am a kind of stigma and diversity nerd. I'm really interested in how the identities that we hold shape and constrain our lives, but also give us strength, beauty, resiliency, and opportunities as well. And so how these different identities kind of push and pull and shape our lives and have downstream implications for health. This is very important to me as a Black queer scholar, but also as somebody who is grounded in a number of communities that face a number of threats to their health and well-being and real life chances. My work does tend to focus on intersectionality and how these different systems of power shape mental health and increasingly other aspects of health, such as sexual health, physical health, et cetera. One thing I'm interested to talk about is also some of the increasing tools that we have to begin to intervene in some of the problems that we see shaping Black queer health today. So really excited to be here and looking forward to chatting and learning from the other panelists as well.
Thank you guys so much for your introductions. It was really exciting to hear about your work, and I'm sure we're going to delve deeper into it as we start to answer some of these questions that have been sent in. So our first question kind of ties into a lot of what all of you guys were saying about your background. And so we hear a lot of dominant narratives around Black queer people are ones of trauma and deficits. We talk about the way in which these populations are disadvantaged or oppressed in society and specifically in healthcare. And this framing is a consideration of structural inequity, and it's important, but we want to open the panel from a different perspective. So what do you think when you think of Black queer people? What do you think are our strengths? What do you think makes us unique? What makes us vital to society, and what makes us vital to science, and even in other aspects like spirituality? So anyone who feels comfortable can jump in. Or
I'm happy. Yeah, I'm happy to start us off. I think when I think about Black queer people, I think about sort of possibilities and like an existence beyond the constraints that this dominant culture, the society often sort of places on us in terms of who we are. I think often we're conditioned to think of ourselves and our identities in certain ways, in binary ways, and very limited ways, which is, again, characteristic, I think, of the society's dominant culture. And so when I think of Black queer people, I think of really sort of expansiveness. And I also think about even the word queer itself. It has this sort of intentional vagueness to it. It's more than, it's about sexual identity and gender identity, but it's much more. And I also think about community and connection, and the way that community keeps Black queer folks, supported and buoyed, and can often sort of buffer from the harm and violence that is often enacted on us by the dominant culture. And I also think of courage and bravery to really chart new paths, to be the first to live a life that is authentic. And so, yeah, those are just some of the strengths that I think about when I think about Black queer people.
Yeah, Dr. Blackstock, that resonated with me strongly. I think if I had to summarize it in a phrase, it would be creative liberation. Because when I think about Black queer people, I think of how we are so often at the front of movements that lead to the liberation of ourselves and others, sometimes not in that order. If we think about the gay rights movement and the Black trans women and Latina and Indigenous women who were also co-conspirators in that, but how we were on the front lines there. And if we think about even present day, when we think about carceral violence, and I believe it's C.C. McDonald, a Black trans woman, their last name may not be correct, but I believe it is, a Black trans woman who was victimized in a very awful way, but who is turned that victimhood into power, and has really been, who was really active in making sure that sort of some of this carceral violence was shown a light on, and how it disadvantaged Black people. And so I just think that Black queer people are magical. That sounds trite, and maybe it is, but it's not by happenstance that people that Black queer people are always at the front of these movements. When we think about one of my favorite literary icons, who James Baldwin, and how he was, while behind the scenes, was really a dominant voice and actor in the civil rights movement, even from behind the scenes. And so I think of creative liberation, I think of solidarity, and also community, how we creatively built the ballroom scene to have a place to validate our identities, because the dominant culture wouldn't give it to us. So we built our own cultures. That's what I think of.
It brings up a lot of thoughts for me, this idea of creative liberation. It's one of the things that really fascinates me as a researcher, because we know very little about this process of creative liberation. But as Black queer folks, we know that it exists. We see it within ourselves and community all the time. But this tension around the focus on stress and stigma and strife came to me in one of the many research projects I was doing on stress and strain and strife among Black queer folks. Maybe about 5 or 6 years ago. And I was looking and trying to capture and study the daily intersectional stressors that Black queer folks face, having them write about it, daily diary kind of study. And I had this moment, at the final hour, what if I also just asked them about the positive ones as well? It was kind of a throw-in research question at the final hour. And the results of that study, particularly the positive experiences, these kind of what I call micro liberations, time that people are really getting free, not despite their Black queer identities, but actually because of them. I thought it was really, really astounding. I remember the first day I read these sort of micro narratives, little things people were doing day to day that were bringing them joy, that they were finding connection in their identity, that they were finding strength, community, creativity. And not only that, the study showed that these things are actually linked to changes in psychological health. So what that means is, yes, societies, homophobia, transphobia, white supremacy, racism are, on the one hand, we know, undermining health for Black queer folks. But the strength that people are finding in community, and from what I could see, the experiences that Black queer folks were creating for themselves, looking for literature that represented them, going and hanging out with friends who mirror their identities. and really carving out creative spaces where they can exist and thrive was really, what I see is like a glitch in the matrix of these identities are not supposed to make us happy. They're not supposed to set us free. They're not supposed to, in the way that they've been structured in society, they're not supposed to bring us joy. And yet, Black queer folks continue to find that, and so I think that idea, to me, it breaks down this notion of that we need to just either study the bad stuff or the good stuff, when really, interestingly, a lot of the joys and wins that Black queer folks are experiencing sometimes comes from the fact of past hardships. Like even thinking about how 2 generations ago, right, our families didn't have that experience. And that actually brings an extra layer of joy when we win, right? Knowing that we didn't have connections or people that look like us at some point in our lives. When we find that, we savor it, right? And we really soak it in. And so this idea that like the wins are connected to the prior losses, that the victories are related to those prior issues we had, I think is where we need to start thinking more. And to really give credit to Black queer folks for, getting lemons and making lemonades.
I'm glad you said that last piece about getting lemons and making lemonade, because I was thinking, I'm a Southern boy, born and raised in Augusta, Georgia, and grew up in the Black Christian church. And it was making me think of something I heard often in that space. It says, taking what the devil meant for harm and turning it into good. And that's kind of what I hear you talking about, Skylar. And so when I think about Black queer people, I think about something that Afrocentric psychologists, doctors Piper, Mandy, and Rose said, that part of the work is to call ourselves into existence. And that is what we do despite the messages that try to story us as a problem, right? Going back to Du Bois's work, right? What does it mean to be a colored person in the 20th century, to be a problem, right? And so, no, we're not problems. Right? We're out here enjoying our lives for the most part, believe it or not, right? Whether people are discriminating on us, whether someone, called us a slur or wished us to hell or whatnot, hey, we take it. It may hurt, but guess what? There's also joy there, right? And there's also ways where I'm going to go kiki with my friends and I'll forget about that, right? So there's so much joy there. And so looking at how do we take that joy and how do we maximize it? We often talk about minimizing the harm, and that's important, but how do we maximize the joy? Because that is there as well. And the other thing that I think about, and then I'll open it up for other folks and hush, but I think about us as healing agents. I do a lot of research around spirituality and health with Black sexual minority communities. And in one of my recent studies, one of my participants said, a lot of us are healers in our families. And we're able to be healers because of that very adversity that we feel like, I don't belong here, I don't belong there. So let me find this space. And in that space, it's creative, it's healing, right? And so not only do we do that for ourselves, but for a lot of our family members, we're the example, or one of the few examples of what this sort of healing and liberation and defining oneself for ourselves can look like. And that ripple effect, by just being us, by just going through our own journey, can also then liberate our families, because we are connected in our communities. We are connected to our families. And again, sometimes our families don't understand it and they may reject us, but we are still that example. And it's an example that they can hold on to if they choose.
Can I just say, I'm sorry, I love that micro liberation term that Dr. Jackson mentioned, because actually it made me think of just microaggressions, a term that I hate. But this idea that it's like, that there may be a book or paper about, it's like a death by 1,000 cuts. But I was just thinking about like how micro liberation, like obviously it can be this cumulative thing, right? Like where if there are like these multiple instances where people are sort of liberating themselves, that can also have a positive and generative effect. So thank you for introducing that term.
And Dr. Lassiter, I feel like you were preaching to me. Like, I'm a Southerner at heart too. That's where I grew up. And when you said healers, I just thought of my own journey with my family, but also like that example rings true to me so much, where how this Black queer person in the family that people don't quite get, they dress a little different, they don't quite understand them, but that's the person they turn to. And I've seen that archetype is so true, particularly in the South, particularly despite what we're told. And then one thing that I wanted to add was that the deficit-centered approach is, I think, inextricably linked to the dominant presence of like a cis heteronormative perspective in research, and that it is no coincidence that this upending that narrative is coming as we diversify science and Black people are being able to lead studies on Black people and queer people. And that's what I think is important for us as far as like representation on this panel talking about Black queer health and healthcare.
Definitely, because as long as that's the main narrative, we can continue to story Black queer people as the problem, right? Look at all these things wrong with them, right? Something must be innately wrong with them, So that's all part of reifying those stereotypes and tropes about our communities anyway.
Mm-hmm. And it's such a complicated thing because, we all know it took a long time for people to even recognize the problems that do face our community. So there is this way in which people assume that they are doing us a favor by continuing to shout and, speak into the mic about the problems. And, and to some degree, we have to keep talking about the disparities and the problems. And yet, it's just not a balanced story. It's not real life. And it's just not true that that's the only narrative, or even that's the predominant narrative of folks' lives. So, I mean, just to go back to we don't need numbers to know this, but just to share a little bit more about looking into what is the number of like positive experience folks have based on their race and sexual orientation or gender identity versus what are the negative ones. In the study that I did, it suggested that on 31% of days, people were finding some sort of joy, strength, resilience, something positive based on their Black queer identity. And that's compared to only 11% of days they said that something negative happened. So if we really do want to talk about the predominant narrative, it is that Black queer folks are finding their way and are finding joy despite the oppressive systems that are around them.
Mm-hmm.
And this is just making me think about just as a healthcare provider, a lot of times we approach our encounters with folks, particularly folks who have intersexing marginalized identities, with like what's the matter with this person versus like what matters to this person. So just like reorienting and reframing instead of pathologizing folks or approaching folks from the deficit perspective, really thinking about, okay, so what are the things that this person cares about, and how can we sort of orient the care we provide to connect with that.
I think that piece also goes into the lack of engagement that a lot of folks in our communities have with healthcare, have with research. We often hear about the disparities in people participating in certain types of clinical trials or, accessing mental or physical health services. But yeah, if I'm going to this place and every time they're asking me about when the last time I had sex without a condom, right? Or, asking me what's wrong, do I want to kill my, all these things, again, not to say that these things are not important, but if that is the predominant message, right, then why do I want to go there? Maybe I'm happy that day, but now I got this appointment. I'm like, do I really want to go there? Because I might leave depressed, So we got to talk about these things. So like, what's going well, right? What's going well for you? I love that, Dr. Blackstock. Yeah.
Well, I think that all of these points are really important, especially when talking about how the Black community and how the Black queer community specifically is important in framing how we look at societal standards and even how we look at standards of healthcare, as you guys have been talking about in terms of research and in terms of the way that we deliver medicine. I think that having more emerging Black queer scholars is important because I think hearing our voices and reflecting the voices of patients who are traditionally marginalized helps us to really collect more data that we might not have had before on these communities, which really actually could impact, like instead of the trickle down effect, the trickle up effect. When you help the people at the bottom, it helps everybody on the way up. And so I think that instead of focusing on, what went wrong with these communities, I think it's important that now we're reframing it and what works right with these communities. How do we get them in the door to keep coming back to these appointments? How do we increase recruitment? How do we make the research that we do sustainable in these communities so that even when the research is done, the results form better health outcomes for the individuals in those communities, or the results actually mean something. Because I think it's going back to what you guys are saying. We're tired of seeing all these stats of Black queer people are dying faster from XYZ, or Black queer people are more likely to be marginalized in these areas. I think that we know that, as even me as a medical student and you guys as scholars now in your careers. I think you guys understand that there is a disparity. I think it's good that now we're talking about how are we moving to make that disparity, how are Black queer people addressing the disparity and making it better, and how can we as a system mitigate so that Black queer people aren't the only people addressing the disparities. So I appreciate you guys' insight, and it actually kind of rolls into the next question about intersectionality, because I think a lot of people love to, whenever you hear Black and queer, I think the next term that people want to say is intersectionality. And I think a lot of people don't really understand what that means, both just the literal term and definition of intersectionality, but also how to apply that in the scope of how are we making things better for Black queer patients, both in clinic, how are we making things better for Black queer research subjects, and how are we making things better for Black queer individuals in their community? Because even if we're mitigating at the health level, if they're not getting that community support, it's always going to fall short. So if anyone wants to talk about intersectionality and the Black queer community, that would be our next topic.
I could jump in because intersectionality as like a theory and analytic is important to me as like someone who tries to consider myself like steward of the Black feminist work that came in the scholarship that came before me. And so we think about Patricia Hill Collins and Kimberly Crenshaw and these scholars who sort of originated this. And if you go even back, like intersectionality, they originated, but like Sojourner Truth was talking about intersectionality when she's studying Now a Woman. These principles aren't new. And so to be quick about it, I'll say people mistake intersectionality as big about identities when it's about power. It's about how overlapping and constituted power structures can pattern our existence in positive and negative ways. And so it's about how, not me being a Black trans woman, but how I navigate the world in a racist and in a system that is subject to systemic racism and systemic transphobia or sexism. That's what it's about, because those identities aren't the locus of the problems. Those identities are subject to the power structures where that is the locus of the problem. So it's structural and systemic, not individual. And then I'll say that the other thing that people miss is that intersectionality was not designed for academia or even for like these like spaces where people talk about intellectual terms. Intersectionality was about justice. Intersectionality came out of critical legal scholarship talking about the plight of Black women. It's not actually, so if you're not tying it directly to pursuit of justice, you have missed the mark. So if it's not about power and justice, you're wrong. And where that pertains to Black queer people is that, and I'm guilty of this in my own work, every mistake that I'm saying has been made, I've made it, so I can speak on it. Where we talk about, where you just see people cross-stratifying in their work and talking about like, oh, when you're Black, you have higher incidence of cardiovascular disease, and when you're queer, you have higher incidence of cardiovascular disease. So when you bring the Black plus the queer, you get a whole lot of that. That is like poor man's intersectionality. But let's talk about how when a Black queer person navigates the world, the unique context of what happens. When they say co-constituted, that means racism is comprised of transphobia. That means racism is made up of these other systems. So they create something totally different when you're talking about someone who exists at the intersection of both of them. And so that comes back to that liberation. My micro-liberations are unique to people who are Black and trans. You can't see them, you can't understand them outside of that context because they're a unique power that I have. And so people think about the deficits from intersectionality, but they don't think about the strengths. Like Black trans people see the world totally different. We see the world in a way that's more flexible. I am often pushing people when they're talking about solutions to, I have way more faith in humanity than y'all are giving us credit for. I believe we can be way more creative. I believe in a system where we could actually cure the HIV epidemic. And because Black trans people and cis Black women are one of the populations that are having the higher last time, Dr. Blackstock will know better than I, but last time I was checking this prevalence figures, that was one of the populations where things were most severe. But I believe that we're capable of fixing this. I believe that we're capable of bringing together solutions that, I mean, I can create my own existence as a Black trans woman. So fixing the HIV epidemic is well within our possibilities. I'll stop there.
No, go ahead. No, you go.
Okay. Yeah. I mean, it's such an important conversation to talk about how we use these terms because, intersectionality is everywhere. And what we know is like when any term becomes popular quickly, it becomes very vulnerable to misuse. And some of that is a credit to the stewards of this work and the relevance of the concept, right? That it gets fuzzy and used in spaces where it shouldn't. But we also do need to be thoughtful and mindful. So I appreciate, and I got very little to say except for yes to everything that was just said about some of the major missteps, right? The tendency to focus on identities, the lack of attention to power and structure, all of that. So I don't have much to add on defining what it is, but I did want to share one of the ways I build it in, or one of the things that attracts me to it in my work is I think many people think about intersectionality as this tool or method or framework to help them grapple with or deal with these multiple aspects of power at the same time. To me, I just think of it as a tool to get closer to the truth, because the truth is that our lives aren't in these different boxes. You are rarely experiencing only
embrace
one
the stickiness, embrace the mess.
Yeah, it's about a way to deal with the truth, which is that our lives, our identities, power structures are messy and overlapping in ways that we both know and sometimes ways that we don't know. And so to me, intersectionality, people say it's inconvenient as a researcher, it's too complicated. And I'm like, but it's also just the way that the world is. So we got to deal with that, right? If we want to be getting close to people's real experiences. And to me, and I think this is one for me, I had an earlier career before I was a researcher. I used to work in the nonprofit sector. And so I worked for a nonprofit organization that was working to reduce prejudice and conflict among teenagers. I was doing a lot of group facilitation, getting people to talk about various aspects of who they are, how they're seen, how they're treated, how they treat others. And I just think about the stories I heard there, the stories of my own life, of my friend's life, of my family's life. And I think about the challenges that folks face, and in particular, the challenges that are stressful, that get in the way of their health. And very rarely do they fall along some single axis of power, right? I think about like my sister is executive director of a reproductive justice organization. She does a lot of work on Black maternal health, right? And so, and thinking about the ways that the problems that organize society cut across these lines. I think about my work in the nonprofit sector and working with, I'm thinking about a young, Japanese coming out bisexual young woman, and how her concerns about her sexual orientation and coming out were really grounded in her culture, and not seeing people that looked like her in the community. I think about one of my friends in college who was a trans-identified man who was in a relationship with a gay man living with HIV, and how it was very hard to find health information that fit his trans identity, their serodiscordant status, and their relationship status. So these are examples that move beyond the Black queer experience. And what I mean, why I do that is that I'm just saying, if we want to get closer to any of the truth of what's getting in the way of the most marginalized populations, we got to be able to grapple with the fact that these problems aren't neat. They don't fit into singular boxes. And so we've got to get more complex ways of thinking and complex tools to deal with that. And intersectionality is the best thing that we've got. Despite it not being made for health research, we can begin to take some of the principles and the motivation from it and start to translate and find new ways to access truth.
Yeah, I wanna piggyback on that justice piece, because yes, like I always talk to my students about, when we talk about intersectionality to me, it's one where you got to be looking at multiple levels. So many people get brought down on those social identities intersecting, like you said, Dr. Lett. But it's also about those systems of power and oppression, advantage and disadvantage. I also think about whose voice is included and whose voice is considered legitimate. Because that's the thing. I mean, we're on this panel now, but in a lot of the spaces that we are in, people challenge the legitimacy of our voices.
Mhm.
People challenge why are you studying, the intersexual stigma among this group? Why are you going to compare them with a white sample, right? How many of us have heard that, right? So it is there's always this question of legitimacy, and intersectionality says that there can be multiple legitimacies, right? And I also think about, again, going back to this justice piece, because we mentioned HIV, and my postdoc was in HIV prevention research, and I submit grants to the NIH about HIV, but it's lucrative. Let's just be honest. There's so much research about HIV because it's lucrative. And I say that because there are other conditions that affect our communities that we don't ever hear a peep about. Why? Because it's not as lucrative. And where's that money going? Most of it is going to folks like us, right? Funding postdocs, funding researchers, funding labs, et cetera, et cetera. It's lucrative. And so the point of research from the model that we have, which again, we have to name it, it's a Eurocentric model. The model that we have from the point of research from a Eurocentric model is more research, right? Don't we all write in our grants? Right? You better make sure you're going to follow up with it, submit another grant, do another research study, right? It's not liberation. It's not justice. That's a system thing, right? But if our voices, people like us, our voices were considered legitimate, maybe we could actually find some justice with our research. But even if we have that motivation, the systems tell us you're doing it wrong. Oh no, your grant's not going to get funded. You're not going to get those nonprofit dollars if you don't say this, if you don't say that. So intersectionality challenges us to think about those multiple levels and how things are working at multiple levels to either push us towards justice and liberation or away from it. That's what I think about.
Yeah, I agree with all that has been said, and just thinking about, I guess, the next level of intersectionality, just thinking about just movements that address, systems of oppression as separate and individual, are, really obviously excluding, large section of the population, not recognizing the ways in which, for instance, racial justice movements need to really be pushing back around patriarchy and homophobia. And that really, the reality is that all of our struggles are linked to one another. And white supremacy, when I think about white supremacy, I think of it as not just racism. I think of it as transphobia. I think of it as homophobia, heterosexism, sexism, ableism. Like, that's all under the umbrella of white supremacy. And so we can't just chip away at one system and expect, things to be better. We need to realize the ways in which these are all tangled together. So just thinking about movements and organizing, because we often see, the different communities, different marginalized communities being excluded. And so, just working obviously towards, more inclusive, equitable representation. But yes, agree with all that has been said. And just thinking also about, think about my own, the research I used to do, and thinking about the healthcare that I provide. I was really excited to see, I don't know if you all know the HPTN network. Dr. Lassiter, you might know it. So there's this 096 study that's focused on Black men who have sex with men, and they're intentionally addressing intersectional stigma. I don't know how they're doing this, but they're developing they're doing capacity building for healthcare facilities to address the impacts of these intersecting stigmas that Black same gender loving men experience. And it's really exciting. We'll see whether it's effective or not, but it's exciting to see this being actually put into practice. Because often, people just are, treated one size fits all. And so it's great to see interventions that are really becoming tailored to address these intersecting issues.
I wanted to share one more thing that was inspired, hearing us talking about the power of voice and whose voice has currency or credibility and who's at the table. I was really glad that made its way into the conversation, because I do think, as we're talking about intersectionality and how it's exploded in the both scientific and lay discourse. As I mentioned before, some of that is, of course, due to generations of hardworking researchers, scholars, activists who have been doing this work and using this language before it was respected, before it was known. But also, it is a product of some initial inroads that we're seeing in terms of changing in demographics in the academy. And again, we got and when I say a long road, a real long road to go. But I do think that it is even the fact that we are here and we have enough of us here, and there are other people to choose from, and there are people who are interested to watch it. That has not always been true. And so I just think this idea of increasing the sophistication of how intersectionality is used, how much people understand it, how much people are interested in it, has to do with the fact that nowadays we got more Black women, more queer and trans people of color, more immigrants, more people living with HIV, people who have been incarcerated, people who have been navigating systems of power are more and more entering graduate programs, are making their way through the ranks of the academy, and are getting a higher profile in other institutions as well. And so I just want to highlight that work, which we are all a part of, but a small part of, which is a growing demographic of folks from the margins who are able to articulate this work, not just because they read it, but because they have lived it.
I think that's so important, but I also, as a person that has doctoral mentees, that is mostly due to us, though. Right? I want to give credit where credit is due, because the process of getting an advanced degree is still horrible for most people that look like us. It's hard to find mentors that look like us. It's hard to find systems that are going to, again, take our cultural backgrounds as legitimate, who's not going to look at us as strange when we ask, so how does that theory apply to what we're trying to do in our communities, right? So that work, it's a lot out of perseverance and saying, as Dr. Lett said, hey, if I can imagine my way from my childhood, I can imagine myself to being a doctor, right? So that's the work on us. I often think about Malcolm X's, like, you don't stab a man 9 inches, pull it out 6 to call it progress, right? So we do have higher numbers, but the system is still very malicious.
Right. And I think just to say, like, representation, obviously we know is important. Inclusion, also, but often when we have inclusion, people are still expected to behave according to the dominant culture's norms.
Yep.
And so, like, I think ultimately, obviously, equity and justice are most important. And, in terms of us being in leadership roles, decision-making roles, roles of influence, I think that's when things are really going to change. And just also thinking about this idea of, like, cognitive justice, the idea that there are all these different sort of forms of knowing and knowledge.
Yep.
And so I think just, your presence, obviously, all of you in the academy, obviously, helps us to move towards that. But there's still, a great way to go. And we still use a lot of the, constructs that, have been used for decades. But excited that you all are doing I'm no longer writing grants and whatnot, but I'm glad that you all are moving the field forward. But just to say, it'd be wonderful, again, just to see this not just representation, but also, people who look like us in power and decision-making roles.
Yeah.
Okay. So, sorry, guys.
You're back.
I figured it out. Sorry to jump in.
It's okay. We're amongst family. Go ahead.
It's just this conversation about intersectionality and kind of the power structure that frames these identities and how people in these identities are treated within a system brings us to another question that was posed that I was hoping that you guys as physicians could answer and kind of delve into and discuss, which is, what are these major health issues that are facing Black queer Americans today, and how they relate specifically to issues that might only face just Black people or just queer people, and how you feel that intersectionality and these power dynamics and societal norms play a role in envisioning solutions for these specific challenges for Black queer Americans.
And just to note, we're all doctors, but not all of us are physicians. There are two. Actually, we only got one physician, the illustrious Dr. Blackstock, and the rest of us are psychologists, or in my case, a physician in training eventually. But yeah, I'm actually really curious to hear what other people think are. And then queer is such a broad umbrella too. But I just wanted to throw that in there.
I had the great opportunity to work with Dr. Lawrence Follins, and we co-edited a book called Black LGBT Health. And one of the things that we learned from doing that is, one, there's not enough information about our communities and our health. But two, is that the major determinant of poor health, of poor health among our communities is intersectional oppression. Mm-hmm. It's intersectional oppression. It's not, poor diet. It's not lack of it's intersectional oppression. Dealing with the day in, day out, having to hear the macro and microaggressions, having to smile when someone offends you and act like they aren't crazy, right? Mm-hmm. So that sort of ingesting the poison on a day in, day out from those systems of intersectional oppression, the resource deprivation caused by those intersecting systems of oppression. I would say for me and the work that I do, both as a therapist, but also as a researcher and also as a mentor to students, that's the common narrative that I hear by Black students, by LGBTQ students, by Black LGBTQ students coming to me like, oh my God, another racist event, another transphobic event, so on and so forth.
I'm just kind of piggybacking off of that. So the one answer, right? The obvious answer is HIV, right? Like we talk about that all the time. And that is not a problem that we shouldn't keep centered. We should keep our foot on HIV. Like that's something we need to continue to combat. But I think part of the reason why it is so, you talked about the money, Dr. Lassiter, but I also think people are comfortable stigmatizing Black queer bodies, and that HIV and stigma can't be, like as a trans person, and I study trans people of color, and it's very sad to see that my handful of papers are some of the only papers that address Black trans health outside of HIV. And it's not to say that HIV isn't an important issue that faces Black trans people, but the reason why, and I'm just going to name it, white people are really comfortable studying that because it's lucrative, and it also stigmatizes us. Now, I don't think HIV should be stigmatized, but it still is. And so that uncomfortable loop of hypersexualizing Black people and hypersexualizing queer people and individualizing and making it something that is our fault, those all tie together. That's why, because a lot of people, there are certain populations that are still in the midst of the HIV epidemic, and there are those that aren't. There's a reason why uptake of PrEP is so high in gay white men, and we haven't successfully integrated that into Black cis women and Black trans people. And so one of my studies showed that Black trans folks have really high, comparatively high, and this is on a cross-sectional survey, so it needs to be followed up, but comparatively high cardiovascular outcomes. So something that the theory behind that makes sense. Intersectional stigma is, you have increased stress, or minority stress framework tells you that you're going to have cardiovascular outcomes. You literally incorporate that sort of stress, and you've seen this on a biological level with elevated cortisol levels. That all makes sense. And so what is the dominant health issue facing Black queer people is structural oppression. Cardiovascular, all these things are when you have severe economic deprivation, which is what Black people experience and queer people experience and Black trans people experience, when you have political exclusion by incarcerating us and then preventing us from being able to vote, that leads to us not having resources, that leads to us not being able to elect our officials, that leads to us being disproportionately, again, economically deprived. Those things are inextricably linked. You have direct impacts of structural racism and queerphobia through the stress framework on your health, and then you have indirect ones by all these other intervening pathways that prevent you to have excess. So, and this isn't to throw your hands up and say structural issues are the biggest health things. That's to say that we know the pathways of structural racism, right? It is employment discrimination. It is environmental injustice and having all the Black people concentrated around refineries so we all have asthma. Like, we know those are actually policy intervention targets. You can make it illegal to put refineries in places that are disproportionate. Like, you can regulate those things. And so when we say, a lot of responses, like when we say it's structural, then people respond and say that's not modifiable. But I have a different framework, and I think about if it's generational or intergenerational. Because, like, one thing about Black people is that we've had to be patient. And so toiling away and working for the inheritance of our children is what my ancestors did. And so, like, I'm not, a big problem is something that, is this something that scares me? It's something that tells me let's get to work now. So even if I don't benefit in my lifetime, people that come after can.
Yep.
Yeah. And just to say, I intentionally did not mention HIV only because I know that's always like the quick go-to. But there's also something you were saying, Elle, right, about sort of the stigmatization of Black folk with the hypersexuality. And it's interesting, there's this article by Kevin, I think Mosby is his name. It's called The Two Regimes of HIV, the Socio-Political Construction of HIV as a Black Disease. But when he talks about basically like this sort of erasure and this sort of hyper invisibility of Black people early on in the HIV, especially Black queer men in the beginning of the HIV epidemic, and then how it's like evolved into this like hyper visibility. And just to also just say that the reason why there's so much funding for HIV research is because white gay men, people listen to white gay men. I mean, we know that Black and brown communities, queer communities have been, advocating since the beginning of the AIDS epidemic for attention and investment to these issues. But, white gay men get listened to. So that's why there is an inordinate amount of funding for HIV. But just to say, though, HIV, though, for me at least, is like the lens through which I see and understand all of these systems of oppression. Like, I honestly cannot think of a condition, there may be some mental health conditions where there's such a disproportionate impact on Black and brown, trans people, same gender loving men. So like, for instance, here in New York City, about like 80% of new HIV diagnoses among Black and Latino, among men or among Black and Latino MSM. Among trans women, about 50% of the diagnoses among Black trans women, about 30% about Latina trans women. So it's just like, I literally do not know of any other conditions that have such marked and stark inequities. But all that to say is that we, obviously we need to dismantle these systems, but we also need to also create, like I was mentioning, care models that really address the impacts of these different systems. Like at the clinic I work at Harlem Hospital, like we don't even have a mental health provider like located in the clinic. Like I'm just like, and the major issues that so many of my patients are dealing with is not HIV, right? It's like survival. It's like staying sane. Just trying to like make it day to day, and we just don't have the supports to provide for patients. So that's all I wanted to say about HIV.
And then you think about. Sorry, and Kim G, you're going to have to reel me in at some point, but I have to add one more thing.
Add it.
You think about, so the COVID pandemic and the disproportionate effect it had on Black and Latina people, old Black people were not surprised. Like this, I think of COVID as an acute shock to an already inequitable system.
Yes.
Everything we saw, despite what people pretend, was completely predictable as far as the disproportionate burden. And we are living through a mass death and disabling event that disproportionately, because the system is already unjust, affects our communities. And so when we talk about structures, we have to think about, this is almost a new structural determinant, this like mass disability event that we're having. And we need to start thinking about solutions for our communities, because we have to think about how we're going to care for these people, for everyone. But because it disproportionately affected Black and Latina people, and because and I suspect Indigenous people as well, I don't think the studies have been as robust, but I mean, the theory, things that happen to Black people tend to happen to Indigenous people. You've seen that demonstrated with the carceral system and the police violence. So we need to think about how this is going to, like, we already have a lot of the Black population sequestered in prisons, not providing economic sort of input into their communities, and then we're going to have them sequestered into like disability as a disabled population. So how is it going to have a kind of community level impact on the Black population in the United States? And more importantly, how can we turn that Black liberatory creativity to mitigate that harm? That's what I want to spend time thinking about in my communities, in our silos, wherever, not just like on this call, but like in general. That's something that we need to foreground as an impending barrier to health equity for our community.
One of the things that I think a lot about as a psychologist, like when I look at some of the major health disparities that face Black queer folks, is trying to look at some of the more, I guess, like psychological or proximal parts of one's experience that might drive some of these downstream problems that we see, whether it is regarding sexual health outcomes or mental health outcomes. And so there is, although there's very little research in this area, there is some emerging on like what some of the unique stressors. So people were talking about stress. So what are these like unique stigma related stressors that Black queer folks are facing? And so some of the ones I think about it in terms of, it happening at multiple levels, both intrapersonally, interpersonally, and at the structural level. And so I'll just share some examples of what some of my team are working on and talking about in our work about some of the unique intersectional stressors. So at the individual level, a lot of the work that we do looks at things like identity conflict that occur for Black queer folks between their racial, cultural, and sexual and gender identities, sometimes also including conflicts between religious and sexual and gender minority status. That does not mean everybody experiences that. That doesn't even mean that most people do, but that it is a unique kind of challenge where people feel a sense of dissonance between their sort of LGBTQ identity and some other aspect of their cultural identity. We look a lot at issues like cultural homelessness, the sense that people feel like they don't belong as a part of the larger, mostly heterosexual Black community or the larger, mostly white mainstream LGBTQ community. And we just know that as like hyper minorities, that these groups face more of a sense of invisibility and with that sense of isolation. And so then on the interpersonal level, we look at things like how hard it is for folks when they have to code switch between these communities. And it not only the mainstream LGBTQ community, if they're a part of that, and not only their mainstream racial ethnic community, if they're a part of that, but also the rest of society. We know that Black queer folks face unique stereotypes that are different than kind of singular dimensional stereotypes. And we also know that these groups face intra-community stigma. So, and that it might sting differently if you face homophobia or transphobia in the Black community or face racism in a queer community.
From my experience, it totally
right? And this is where the research is that it's actually qualitatively different when you are rejected and when you're seeking safety and seeking a home, and then you experience rejection. And that's what makes it an intersectional experience, because it's a different flavor and a different sting, right? And then the last thing I'll say, there's more examples at every level, but then at the structural level, there's some really interesting work that is coming from some other research teams that's looking at how many of the laws that we think are like structural homophobia are actually like anti-Black structural homophobia. So one example that people talk about is HIV criminalization laws and their impact in the LGBTQ community, and how people tend to frame this as an LGBTQ issue. But what we know is that the way that these laws get implemented have disproportionate impacts and are disproportionately targeted towards Black bodies, Black and brown bodies. And so, and that's just one example of many, is starting to think like, what does intersectionality look like at the structural context, in the structural context, when we think about laws and policies and things like that as well. So that is one slice of this work of thinking about what the unique problems are. But that's where most of my work focuses on, is like, what is the daily and then occasionally structural ways that that Black queer folks face things that their white LGBTQ counterparts and Black heterosexual cisgender counterparts don't face.
Thank you for that, Dr. Jackson. I'm sorry.
I was actually going to transition. Well, I don't if you wanted to finish your thought, because you actually opened up to another question that we had. But if you want to finish your thought, Dr. Lassiter, definitely go ahead, and then I will.
No, I just wanted to address Dr. Lett's question, because I think the question you asked is, how do we change the tide? And for me, as an Afrocentric psychologist, I'm thinking we change the tide by embracing our culture. The answers are there in our culture. It's African-centered values, like prioritizing relationships over everything else, right? If I truly believe myself to be interconnected, right, to you, then I can't do harm to you. You can't do harm to me, right? My success is your success. So how do we bring together the very best of our communities for the collective good of us all? Right. I think about understanding ourselves to be holistic individuals that are not just tied by our biological existence, but our spiritual, our energetic existence. Dr. Lake, you talk about that intergenerational work, right? So from this perspective, there's a very real benefit from doing that work for the next generation. We benefit from it today when we do the work for the next generation, but everyone doesn't have that lens. We're often taught to think very individual. Even in our activism, we thought, what is the one thing I can do, right? Instead of what is the thing that we all can do. Right. And so how do we get more voices to the table? How do we see ourselves as interconnected and interdependent more? That's in our culture. That's in our cultural heritage. And we've sort of all been socialized into this individualism, into this competitiveness, but it doesn't have to be that way. So how do we change the tide? One of the ways is going back to the culture that's already rooted within us and that our ancestors had with them before they became enslaved chattel.
That is actually, Dr. Lassiter, that was actually a perfect segue, because when we're talking about intersectionality and people looking at within their communities for resources and for solidarity, you have to ask, how do you find solidarity in the Black community as a queer person? How do we start moving forward? How does that look in the spaces that you individually occupy? And how do you feel like that looks in spaces for other Black queer people? And how do you think that you can use your background in either science or research as advocacy in those spaces?
Yeah, this is something that I struggle with, to be honest. So, and this is like a conversation like this isn't part of the Black Queer Town Hall, right? So it's for Black and queer people, but it's going to be consumed by people of all backgrounds. And so it's uncomfortable to talk about some of the homophobia and transphobia that exists within the Black community in like mixed company, is what Black people would say. But like the reality is that's there. And if it's disproportionate to other communities, I can't answer that. But I know I feel it disproportionately painfully from this community when comparison to other ones. And so like I say this, and this is difficult to acknowledge in the concept of intersectional theorists, but like I've been Black a long time. I lead with my Blackness. Like my transness is related inextricably to my Blackness. Like I am in healthcare to protect and to serve Black people. I'm going to treat all my patients, obviously, and I care about all their well-being. But what drew me here was the harms that I've seen visited upon Black people to be a barrier to them in the future. And at the same time, I experience so much rejection. Maybe it's not more, maybe it just hurts more from Black people. And in academic spaces, it's not the same thing. But like I grew up in a rural South. And so when you talk about like organizing and support on behalf of the Black community and then go home and you're not actually supported by that, that's difficult. And it's hard for me to like instill, because I'm like a very mature scientist in some ways, but it's hard for me to instill that value of centering Black folks and junior trainees who happen to be Black and queer who talk about the transphobia or the queer phobia they experience within their community. So I think some of it is where like and to what degree is all of that transphobia, homophobia really just the output of white supremacy, right? And even if it is, how does that matter? So this is an open question for me. Like, how do I inspire support from a community that I am giving my love to, but that often rejects me? I don't know.
Yeah, it was something that I think Dr. Lassiter was saying that made me think about, like, you said going back to who we are, going back to, I don't know, before we were, colonized and kidnapped from our ancestral homelands. This reality of like things like transphobia and homophobia, that's not us. Like, I think Black people need to realize like that's something that we've been conditioned into and indoctrinated into. Like, this is not who we are, who our ancestors are. And, you see like cis straight black men holding tightly to patriarchy. People joke how they're the white people of black people. But it's just like we need to realize this is like what has been like placed upon us and what we're burdened by, and then what we are like at the heart of who we are, and who our ancestors were. So I'm sorry, it just made me think about when Dr. Lassiter, you were talking about sort of going back to who we are, about that. So I just wanted to just remind everyone that we're not, and I appreciate, Dr. I appreciated your point about, you don't know whether homophobia or transphobia is worse in the Black community compared to the white community, but for you, the impact, it hurts more when it's from your own people. And I think that's such an important point.
And I think, sorry, I just want to add one more thing I wasn't going to share, but I think it's important. So as a Black trans person, like seeking like connection, like navigating like apps and stuff at a period of my time when I was like on dating apps, some of the most like challenging or transphobic things I would encounter would come from gay Black men, right? And so, and that's like, and I say that because I'm not alone in that, but we need to like I recall conversations where, and this is a health thing, right? This is how people like seek. This impacts people's sexual behavior, which impacts their health, right? And so this is important for this panel. But combating that intra-community transphobia and rejection is, I think, an important barrier to coalition building, which is where we get our collective power and can really do change, and also to protecting ourselves. Because so much of that, I think you're right, is internalized from things that were not us, but how do we call ourselves in to change it? Dr. Lassiter, I was cutting you off, and I apologize for that.
Oh, no worries. Thank you so much for those insights. It really makes me think. What I was going to talk about though is this question about how do we connect as Black queer people with Black heterosexual cisgender folks, and it is a problem. On some level, a lot of us have experienced rejection and exclusion. And I know I definitely have it. Like some of my family members don't really even know how to talk to me, right? It's just like, I'm still the same person I was, but I think part of that is that in general, and I don't want to let me take that back. I don't want to overgeneralize. For a lot of us, a lot of Black families are dealing with intergenerational trauma, period. And so when we talk about the queer experience, it's boom, right? Because it's seen as a vulnerability. And for a lot of the previous generations, there was this real emphasis on just physical survival. And that physical survival because of the white barbarism, right? The terrorism at the hands of white people because of who you are as a Black person. Now you add the queer experience on top of that. Oh my gosh, someone might, queer bash my child.
Yes.
Or live in an HIV epidemic too.
Yeah, right. And you might die, right? You might get HIV and die. A lot of Black people still think like that, even in 2022. So when you have these compounded things, parents, their way of protecting you could end up hurting you. But in their mind, they're trying to protect you. You get what I'm saying? Yeah. So when I think about how do we start to have those conversations, and I can only share my testimony, right? I don't have the answers. But part of that is by letting folks know, I understand where you're coming from. I understand that what you're doing right now is you're actually trying to save me. But here's a better way to try to do that, right? And some people will be open to that conversation. Some people won't. And one of the things that my husband told me was that live your life. Sometimes it's not about saying something with your words, but showing it with your actions. My father, Black man, recently passed last year, but he was born in the 1950s and he called me Slim. He said, Slim, I was scared for you all the time. But when I saw you move to New York City, you moved out to San Francisco for graduate school, you survived. I'm proud of you, son. So all the stuff that he said about being an F word and all of this stuff, he got over it because he understood that I was still safe. And that's all he ever wanted for me. So figuring out how to have those conversations, and maybe I mean, I'm not saying there are parents that got hate in their heart. Some parents got hate in their heart, but most parents, I venture to say, really want what's best for their kids. And so it's about maybe having a conversation about what best can look like.
Yeah, I actually do agree. I think that all of the points you guys have made are really amazing, and I will let Dr. Jackson speak. But I did just want to bring up the one point that I think Dr. Lett kind of touched on this earlier. I think a lot of homophobia is really adjacent to white supremacy, and I think Dr. Lassiter also hit that on the head. Sometimes I think the homophobia and the queerphobia comes from the fact that a lot of parents, especially me, like I'm a daughter of immigrants, they're already thinking you already have such an uphill battle. You're Black and you're a woman in America, and it's already going to be this much harder for you to get where you're going. And then for you to also be queer or gay or trans on top of that, I think it really is just, you're just adding one more like notch in the belt that like white people already don't like us. And you're taking us, I think that a lot of safety for especially Black people comes, and not just Black people, I think all people of color, the safest place you feel is like closer to a white person, like whenever you feel closely identified to them, because white supremacy protects traits that are closer aligned with that system initially. And so I do think that people try to assimilate to that system of white supremacy for protection, and it winds up manifesting as in horrible ways. I don't think it's an excuse, but I do think it's that protection of maybe if I act a little bit more cis and more white, people will leave me alone. And whenever people see you acting queer and you're happy and you're accepting that, it's a little bit of, one, now I'm in danger because I don't want them to think that I would do something like that, but also maybe a little bit of jealousy of you were able to find that community that made you feel safe enough that you could step away from the whiteness and or the supremacy of it and do what you wanted to do. So I just wanted to add that before I let Dr. Jackson speak. I'm so sorry for interrupting.
It's great. I've been having a million thoughts, and I'm just always like, whenever I talk, I'm going to go with the last one, which is directly related to what you shared. Because that brought up even new thoughts for me. I mean, one of the things that I think about a lot is how yes, this idea that structural oppression, generations of oppression, white supremacy has contributed to, and in many ways invented, the forms of homophobia, transphobia we see in the Black community, 100%. And then on top of that, white supremacy gives us a lens that makes it very easy for us to see and interpret, and even does work to amplify Black, like homophobia in the Black community, because it fits into these stereotypes as the backwards, uneducated Neanderthal Black person, right? And so there's this ways in which the white lens actually fuels this notion, which again we all here agree. There are issues in the Black community. It hurts us. It hurts people we care about. Nobody's denying that. But again, the narrative is actually perpetuated by a lens of white supremacy, which is very good at seeing how Black folks are anti-LGBTQ, but is not good at detecting and amplifying the unique ways that Black folks also navigate these issues, care for folks, acknowledge the queer person in their environment without using that word. But we have our own ways, and those are not detected. Those are not talked about. Those are not amplified. And so we get an imbalanced story where they're really able, where all of us, and I would say even for myself, I end up getting more practice. I get more practice talking about Black homophobia. Nobody asks me about the complicated kind of cultural dances that we do to really deal with and talk about the ways that gender nonconformity, that a variety of sexual orientations, the way that we care and protect and refer to, those things are invisible to white folks and are invisible in the dominant narrative. And so I just want to bring that in, that also contributes to this tilt, the singular narrative that when it comes to being queer, you don't want to be in the Black community. So I just wanted to add that piece.
That is healing for me. Thank you. I appreciate that thought. I hadn't thought of it.
Well, I mean, that was a perfect way to wrap up that question. And honestly, to really summarize, I think what a lot of Black queer people like Dr. Lett said, needed to hear. So thank you so much for that contribution. And honestly, for all of you guys' contribution, we're getting to the end of our panel. Unfortunately, I wish I could just go on, but unfortunately, I do want to ask you guys one last question before we leave, just so that we can kind of summarize the experience, and also so that our viewers can get a piece of you before we leave. And that question is, honestly, how does the work that you do, what does it mean to you, and how does it sustain you as you go day to day as a Black queer person? All of you, please answer.
Well, I sustain myself in this process. Things like this is very sustaining for me. Like when I said what Skylar said was healing, like that was meaningful. Like I had not caught my own conditioning to only see the homophobia and not see the unique ways of affirmation. But as soon as you said that, I like saw the moments where like a Black woman will like walk up to me and say stuff like "I love your hair" or like "I love your rap," or like one of my neighbors saw me transition and this Black woman made me a wig and like stuff like that. Only Black people really do and live that way. And so like, and that had that conditioning, that unpacking, really white supremacy. This is sustaining me by learning that I commune with my body in that way. And also I purposively build community, like really, really stringent. Like that is my core being as academic. I think an academic's legacy is the number of people that confer academic privilege to. Unfortunately, so much resources is wrapped up into degrees that relates to health justice, and I don't think it's right, but it is true. And so while it is true, like I spend a lot of my time bringing other people into the door. I'm a great writer. I can't write as much as 20 people who I help train can write. I just would never be able to do that. And so that sustains me, seeing my imprint and also, like, I experienced so much violence in my training. Helping people not have that violence happen to them sustains me in ways that you can't imagine. And I'll stop there. Especially Black, Indigenous, and Latinx queer people.
Yep.
Thank you, Dr. Lett. Dr. Lassiter, would you like to go next? What sustains your work?
Yes, what sustains my work? That's easy. The spirituality. Right. My main research focus is on how spirituality influences health. When I work with my psychotherapy clients, I'm often bringing in spirituality and culture into the work that we do in that space. So spirituality, understanding that my body does not end here. Right? My connection does not end here. I will continue on. My legacy will continue on. My energy will continue on. To be able to feel, Black people, we often talk about vibe, right? To me, that's spirituality. That's spirit right now. I'm feeling someone else's spirit, right? I love that. I love being with a client and I don't have to say any words, but we are just in the room together and there's healing taking place because two spirits are in conversation. Right. So the spirituality sustains me and my culture sustains me. All these books back here, right, are all around my office. Right. They feel written by beautiful, brilliant Black people, pioneers, and that legacy. I'm like, listen, I could do anything. All these Black people have done this. I could do anything. So that sustains me. And as Dr. Les said, sharing that with the people coming behind me. Listen, you belong here. People talk about imposter syndrome. I say, what's that? Didn't you work for this? You belong here. Let that go, right? Because this is your birthright. That sustains me. And so thank you so much for having me in this conversation. I'm hyped. Let me hush.
I'm very happy to see your hype, as I'm sure everyone on the call is. And thank you so much for your contributions. Dr. Blackstock, in your work, how do you sustain yourself?
Yeah, so I think all of the work I've done, being a physician, being a researcher, being a public health practitioner, and now leading a racial equity and health equity consulting firm, it all feels very mission and purpose driven. I honestly believe, and I know I have a twin sister, and we've talked about this a lot. I really feel like my purpose here on this earth is to move us, even if it's incrementally, towards a more equitable and just world. And so much of my own beliefs, were instilled in me by my parents, my father who immigrated here as 17-year-old from Jamaica, and my mom who was raised on welfare by a single mother along with her 5 siblings. And I'm just a product of the hope and the optimism that they had. And so that really pushes me forward. And I think conversations like this and being community with wonderful spirits like all of you. And then also, again, mentorship is incredibly important to me, and sort of sending that elevator back down to bring people up with me. I think those are the most important parts of this. So thank you so much. Such a pleasure to be here. Thank you, Dr. Lett, for the invitation. It's been really wonderful.
Thank you so much for your contributions, Dr. Blackstock. We are so happy that you came. And now we have Dr. Jackson. In your work, how do you sustain yourself, both in your work and in life?
I don't know if I'm the one to go last. I feel like my answer is, I feel this is a hard one for me, honestly. This is a question that I'm constantly asking myself. How am I sustaining myself? But I got some answers, and then I got some confusions too, but I'll try to share both of them. I think that, I know for a long time, the way that I've made it through, the way that I've kept staying inspired and kept moving is by finding joy outside of my work, outside of my productivity, outside of what capitalism has taught me matters, which is like how much I produce, or how quickly I move through the ranks of the academy, and really finding joy in community and people, and really specifically in art, whether it's film, dance, like things that connect me with culture, and in particular with stories. Like for me, stories is often where I start with my research. I don't think a lot of researchers, maybe everybody's doing that, but for me, it's like literally often personal stories that I start to think about, that come up more and more, or I hear patterns. And that is how I get to my research ideas. And I think that is why some of my research ideas are different than maybe what the field has produced before, because I'm not looking at, this last study did that, and there's a gap that I'm supposed to build on that. I'm coming from life for me. And that's where I like to keep my work, the seeds of my work, grounded. The mentorship thing I won't reinforce because it's been said over and over, but having mentees, I'm just at the point where I have the capacity, the time, and the money in terms of like grant funding to be able to hire folks within the community. And so I won't reinforce that, but being able to guide and shepherd, and in some cases protect folks in ways that I was not, is really healing. But then I'll say the hard part is that even with all of that, there are a lot of days when I feel like it's not enough, like what I'm doing is not happening fast enough, that doing it in this way, like going for a PhD and writing papers that go into academic journals and giving scholarly talks, is not the move, that it's not going to have the impact, that I'm spinning my wheels. It weighs heavy on me, because at the end of the day, I care about justice, and that's why I'm here. I'm not a health researcher or a psychologist that happens to be interested in justice. I'm a person who's interested in justice, that decided that this was the path where I thought I could make the most difference. That's for me, how I landed here. And so the last thing I'll say, it is very trite and maybe makes me seem, in need of validation. But one of the things that gets me through when I'm really struggling is when somebody, an individual, tells me that my work matters to them, that they read something or they heard me speak, and that they remembered something I said, and that it mattered. Because in this world, as a researcher, as an academic, the work you do is very thankless. You send it out into the void. You work for so many hours, and you never know if it has any difference. And then every once in a while, unfortunately not frequently enough, you hear from somebody that read something or saw you give a talk or saw your name somewhere acknowledged in a book they read or something, and they say that it matters. And it really gives me that extra amount of energy to persevere, because it reminds me that this work that I'm doing is not just going into the void, and that if I'm making such a difference now and connecting with people who are also struggling in their journey, think what I can do as I have, more time in the field, more connections, more experience, and hopefully continued energy. So I want to say, as everyone else did, thank you for allowing me to be a part of this. It's been a pleasure not only to have a platform to share some of these ideas, but to talk about it within community with folks. And I also have just learned a lot from listening to you all and am inspired because I'm thinking about many of the concepts that are always bouncing around in my head in very different ways. So appreciation for the space and much love for the other panelists.
Thank you so much for finishing us off that way. I will say, as we wrap up, as a medical student, what is sustaining me right now is you guys. Honestly, it's so nice as a young Black queer person to have such prominent people in academia take the time to explain your experiences, explain your research, and just have a little kiki, today. This was a lot of fun. And I really appreciated it. So I just want to thank you all so much again for coming here and participating in this year's Black Queer Town Hall. It has been such a pleasure moderating this session with just these amazing academic scholars. And I'm sure the viewers are going to love what all of you guys had to say. I know I learned a lot as a student, and I hope that we will get to see some form of you guys in spaces like these continuing to do this type of work soon. So thank you guys so much for being here.
Yeah.
Woo! All right. That was an amazing discussion by our panelists on equitable healthcare for the Black queer community. I was particularly moved by the discussion of how the Black queer community has created spaces for themselves to heal each other and uplift one another, as well as the emphasis on strength-based approaches to moving toward health equity. Black queer people are not just our trauma. We are also our strength, our power, and our joy. And that's why this entire Black Queer Town Hall event in STEM and healthcare is so important. Now, let's move on. All right. So our next panel is focused on combating the misinformation and pseudoscience of the anti-transgender movement and discusses the current sociopolitical landscape that is limiting healthcare access and justice for the transgender population in the U.S. This panel will address the misinformation around gender-affirming care that has been used to justify legislation to eliminate life-sustaining treatments for trans individuals, and especially trans youth. Key topics include medical and surgical gender-affirming procedures, as well as discussion of the scientific evidence in support of providing trans-affirming care. Thank you. Please enjoy this very important panel and take some notes. I will.
Hello, everyone. Welcome to the Black Queer Town Hall in STEM and Healthcare panel on combating the pseudoscience and misinformation of the anti-transgender movement. I'm your moderator for this panel, Dr. L. Lett. I'm a postdoctoral fellow at the University of Pennsylvania, and I'm also an MD candidate at the same institution. And it is my privilege to facilitate this wonderful panel with such an esteemed group of guests. The Black Queer Town Hall in STEM and Healthcare has been about highlighting the power, strength, and resilience of Black queer scientists, giving them the opportunity to share their science and also share how that science relates to advocacy. This panel is unique in that it also highlights another important population, and that is the allies who support us in our work. And so this panel is not composed of all Black queer people, and we will let people introduce themselves and whatever identities they find are salient in a moment. But I just want to remind everyone that we need allies support, we need cross-movement collaboration. That's why I, in selecting the people for this panel, thought even more broadly, just to really get some experts in the room, but also just some people who I know have been committed to the advancement of transgender people and Black trans people and Black queer people. And so with that, I'm going to let everyone introduce themselves. Remember to give your pronouns mine or she and her. And we're going to start with Dr. Fullerton.
Hello, everyone. I am Dr. Fullerton, Far Amoy, as my friends like to call me. And I am a pediatric resident in Georgia, and I was born in Jamaica, and I moved here in 2003. And since then, I've been really committed to exploring my own identities and making sure that people who have similar identities to mine or marginalized identities close to mine feel accepted by healthcare workers in general. And so that is why I'm here. Dr. Lett said I should plug Med Grad Wish List. And so that is her movement that I've been working on that assists graduating Black and underrepresented medical students in their transition from medical school to residency. A lot of people don't know that that is something that takes a lot, thousands of dollars that our schools do not usually provide for us. And as a population that has been historically disadvantaged with a ever widening wealth gap, I thought it would be pertinent to start something like that so we can get even a little bit of support from not only people in the field that are welcoming these new grads into their fold, but people outside of Med Twitter and beyond. And so that's me. I'm happy to be here.
Thank you, Dr. Fullerton, and their pronouns are they and them. And next is Dr. Garofalo.
Hi, I'm Rob Garofalo. I use he, him pronouns, and I'm kind of using my iPhone, so hopefully it's going to work well because it's a little janky. But I am a pediatrician. I'm the division head of adolescent and young adult medicine at Ann and Robert H. Lurie Children's Hospital, Chicago, and I guess I'm a professor of pediatrics at Northwestern University. First of all, it's a real honor to be here. Thank you, Elle, for inviting me. I love having discussions like these. I've been doing this work for trans people for my entire career, really since before a lot of people have been. I really came at this work through originally through an HIV lens. You know, I came of age during the height of the HIV epidemic, and if I had to tell one more largely Black or brown young transgender woman that they were HIV positive, I really found I couldn't bear it anymore. So I believe in that early medical treatment for young people really makes a difference and will change the course of young people's lives, particularly in Black and brown communities, which Elle and I have talked about this, are still not accessing care, and many of the clinics, including my own, in the numbers that I wish they would. And so anyway, I'm here to listen as much as participate, but it's a real honor to be here, and I appreciate the invite. Thank you.
I'm very thankful for your inclusion. Dr. Garofalo is actually my mentor's mentor, Dr. Nadia Dowshin. So we're connected in sort of a rich history of science and advocacy for trans people. Dr. Williams.
Hello, everyone. I am Marcel Williams. I'm originally from Long Island, New York. I am an incoming family medicine resident, and I am currently in Washington, D.C., but I will be moving back to New York to start my residency in a few months. I am also affiliated with the National Black Trans Advocacy Coalition that's based in Dallas, Texas, where I work to help Black trans people get access to gender-affirming care as far as surgeries, hormone replacement therapy, other health products, housing, and employment.
Thank you, Dr. Williams. And last but certainly not least, Dr. Butler, could you introduce yourselves for our audience?
Hello, and thank you. I'm Dr. Christy Butler. My pronouns are she and her. I'm an assistant professor in urology at the University of California in San Francisco. I am a gender-affirming specialist and urologic reconstructionist. I am just so happy that this work is being done and just feel so privileged to have been invited to sit on this panel. So I'm very excited to engage in conversation with you all and learn something.
All right, now that we're all acquainted with our amazing guests, let's dive right in. So just to get us started, this panel is really to unpack some of the pseudoscience and misinformation that is rampant in the anti-transgender movement. One of the narratives that is used to sort of get fear and have people be afraid is that trans kids immediately want to surgically alter their body. And we'll unpack that a little bit more, but I want us to sort of have a little bit of dialogue around the diversity of who's counted under the trans umbrella and what those identities might have in relationship to potentially surgically transitioning or not. And I want to start that with Dr. Fullerton, and everyone can answer too.
So thank you for fielding this question past me. And so what I wanted to start out with is just some basic definitions of sex and gender identity. And so in places like the US and even my home country of Jamaica, sex and gender are often used interchangeably when they are not necessarily that. And so being born with a penis or vagina or some mix or spectrum of the two, which would be classified as intersex, does not really tell you what that person's gender is going to be. And we can talk about milestones, developmental milestones, and when a child should be able to recognize their sex from being different from their counterparts. But I just wanted to make sure that everyone knew, and everyone who's listening in, that sex and gender are not necessarily the same thing. And so when we talk about trans communities, these are identities that exist very differently from what they were assigned at birth. So there is sex or genders that you are assigned at birth, and that is based on your organs that you're born with, not necessarily what you identify with and what you grew up with, or what you feel that you are supposed to be living as. And so there are a lot of things that exist as far as identity-wise under the trans umbrella. There are people like me who are non-binary and do not really abide by boy, girl, or things like that. And then there are people who are born as one sex but identify as the opposite gender. And there are a lot of colleagues of mine, even on this chat, that can speak more to that. But I just really wanted to make the difference known between the two, and how many different ways there are to express that. And so while a lot of people only have the two binaries in their head, there's so much more that can be given in any state, region, and there are even other cultures that have things like two-spirit and things like that speak more to gender identities that do not fit in a traditional box. So I'll just let anybody else speak in.
Yeah, does anyone want to add to what Dr. Fullerton was saying? One thing that stuck out to me and that I kind of want to hammer home is that there are people with sort of like trans binary identities who identify as men and women. And then there are these non-binary identities like Dr. Fullerton said. And Dr. Fullerton themselves identify as non-binary. And then you have gender non-conforming and gender queer. And all of these people can identify along or outside of the gender spectrum. And not all of those, or not even most of those people, may necessarily desire surgical transition. And so just because a child says they are trans does not necessarily mean that they will need to go through or will even desire or even have changes in their like physical body. Dr. Garofalo, could you talk about how often in your clinic you see trans people or trans youth, and sort of what amongst the like suite of options, so to speak, what their transitions really look like?
Yeah, I mean, I think so much of this is about demystifying this binary notion of gender and how you can achieve like one identity versus another, and this fallacy really that it begins or starts and begins with like medical or surgical interventions. And we know that a robust understanding of gender and thinking of it as of course, a spectrum that's natural across the human condition as opposed to an affectation allows young people and families to then make decisions for themselves that fit. And so it's really not uncommon for some of our patients, especially the adolescents, to not necessarily ultimately want a medical or surgical intervention right away, right? They perhaps want time to explore a variety of options. And it's actually something that even in my own career has changed significantly, I think, over the past certainly 5 to 10 years. Earlier in my career, I felt like I saw mostly young people that walked into my office and said, I want my hormones and I want them yesterday, not today, not tomorrow. I want them yesterday. But increasingly, I think as culture, as popular culture, I'd like to say continues to demystify this binary notion of gender. I do find my patients coming in a bit more open to taking time to explore, what it is they truly want for themselves, and as they live their lives with a degree of authenticity that I think wasn't even available to sort of young people a long time ago. So it's as I would have liked to have said that the world would continue to get more progressive in this field, and we all know that it sadly hasn't. But in certain circles, and I think the ones we're talking about now, it is continuing to get progressive, and that breaking down of the binary and the deconstruction of what it means to live your life authenticity, I think, continues to extend itself in ways that allows for to not use medical interventions or surgical interventions sometimes for these patients. And so I think it's increasingly common.
I agree. I'm sorry.
Go ahead, Dr. Butler, please.
No, I was just going to add to that. A lot of times I think, as you're kind of alluding to, the way that society, the expectations of society, right? This binary narrative that people have to fit in. People feel the need to kind of hide portions of themselves. Oh, I have to pick X, Y, or Z, X or Y. And I think as we become more accepting, we become more knowledgeable, we start realizing that, there's a whole spectrum that people can fall into, and that it's okay. And if we can embrace that from the medical field and support patients as an individual, and not just this, societal expectation of it on this binary nature, right? Where people need to fit in. And I think, we'll probably get into this a little bit later, but just even exploring, treatment or no treatment, surgery versus no surgery, or types of surgery. We've kind of explored more of these less common surgical, like penile sparing vaginoplasties or nullification. So I think being open to that, I think if we as a medical field can embrace that, patients will probably feel more comfortable coming out as their true selves.
Dr. Williams, do you have anything you want to add?
Yeah, it seems everyone is spoke so well on and taking all the good points, but I will just add that oftentimes when people announce that they're trans, just to reiterate what everyone else was saying, it doesn't necessarily mean that they want surgery or hormones. It could mean that they want to change their name and have a name that is more fitting for them. They may want to experiment with different clothing and dressing in different ways that society may not dictate is appropriate for certain genders because of their understanding of the binary. They may also want to just have be addressed with different pronouns. So just because someone says that they're trans, it doesn't necessarily mean that there is a medical intervention that needs to take place.
Thank you, Dr. Williams. And that was actually such an important addition, because that's what you're talking about is social transitioning. And we're going to talk about that in a little bit. But I want to sort of synthesize something that, if I could distill what was said, is just that I think a lot of the fear that is sort of captured with the anti-transgender movement makes people afraid to engage with trans people. But when you do, you realize the creativity and understanding our genders that we have. And I think that'll serve to demystify and sort of dispel a lot of this fear, because we don't see things binarily. We don't see things black and white. And so our genders are so much more fluid and just expansive. That's why people say gender expansive. And I think if we can get past some of this fear and hate, honestly, and discrimination, we'll see that a lot of the fears are unfounded, because they're putting people into boxes that within the trans community don't necessarily exist.
It almost feeds into the right's talking points, right? To feed into these discussions about medical and surgical interventions as being the only way to achieve a trans identity, right? It's let's not take the bait, because we all know that that's not true. And I feel like if we only talk about medical interventions and surgery, we're feeding the right their talking points, when we know that a more in-depth understanding of gender is certainly not that. So I get riled up about these things sometimes.
We love it. We love the passion. And sort of related, a lot of people say, particularly on the right, and some of the anti-transgender proponents say that children are too young to know their gender and if they're trans. Like, how would you respond to this claim, either in your own experience or from a pediatrician standpoint or from an evidence-based standpoint? Like, when does gender formation occur, and when can children speak with some authority about who I am, what is my gender?
And so Dr. Garofalo is definitely a more senior pediatrician than I am. I've only been practicing pediatrics for a very short time. But even in the books, you're taught that kids start to recognize their own gender and sex at a very young age, between 3 and 5. And they start that by noticing the differences between themselves and the people around them. And so when people say, oh my gosh, it's too soon for these kids to be dealing with homosexuality and things like that. When that baby who was out of the womb barely can't even talk, you were talking about, oh, that he's a ladies' man. He loves, like, you are already pushing your own ideas of sexuality on this child before they can even speak. And so when people try to turn it around and say, oh, it's too young, it's only too young because it's something you're just not used to. And you're just not comfortable with a child owning their own identity, being so independent from such a young age to where they say, this is who I am and this is who I want to be. And hey, it might not be the same exactly a year from now, maybe 2 years from now, but like, I think this is important to me right now, and it's affecting me in a way that I feel like my support system needs to adjust to. And so I think that is one of the biggest things is like, you gotta make it 1 for 1, because it's not fair to have those standards.
Yeah, I mean, I agree with all that. I think this is where there's just this complete conflation, right, between like gender identity and sexual orientation, right, that continues to plague this discipline, right? And I mean, yes, sexual orientation is more of an adolescent construct, but dear God, gender isn't, right? I mean, we all know that gender is an early childhood pediatric construct. And so I don't understand like why, if a 3-year-old or a 4-year-old who happens to be trans identified doesn't know their gender, then neither can cis kids know their gender at the age of 3 or 4 or 5. And we all know they do. So whenever I see like an opponent talk to me about their own child that's 3 or 4 or 5, and oh, isn't she a cute little girl? How do you know? If we can't make these decisions for trans kids, then it's got to be true of everyone. And so it's just another area where I think, where it's just a complete perversion of what we understand about human development and child development. It's just understanding your gender is at a very early age is consistent with every notion of childhood development.
Yeah, and I think part of it is the challenge of like conflating like LGBT as one sort of movement, which again, I believe in solidarity between queer communities, but I do think distinctions are also important because sexual orientation, as Dr. Garofalo said, is something that happens later in life, but gender is early, and we know that. I've known that I was trans forever, as long as I can remember, and that's not it's not an uncommon experience amongst trans folks. Another thing that I want to get at while we're here, and I hate giving further credence to this, I think particularly egregious example of pseudoscience, but I think we would be remiss not to address it. And that is the Littman paper on rapid onset gender dysphoria. I say this paper, I reference this, and I'll give everyone sort of a rundown. I reference this paper because it is one of the things that is often used, weaponized against the transgender movement, that basically the idea is that people are becoming trans because because trans is in fashion. And it was written and published, and I want to say that rapid onset gender dysphoria was a term coined on the basis of a scientifically invalid study. And I'm happy to talk about why that is, but Dr. Garofalo, I would love if you could provide some thoughts as sort of one of the scientific leaders in our field as well.
I mean, I don't even know where to begin. It's such a flawed study that it's only getting traction because I'm sorry, the conservative movement and the right want something to use as a wedge issue and as a pivot. I mean, very clearly their methodology and the way they collected the data has so much inherent bias that I don't even know why we're giving this paper credence. It's just that then not only did she write that paper, but then people like, Abigail Schreier or whatever wrote that book, which then is at airports across.
Dr. Garofalo, could you quickly say sort of what the paper said and what they claimed, and then
I mean, I don't have the details in front of me, but it's, they basically claim that there's this trend towards essentially the encouragement of people to take on trans identities, and that it's been, so I don't have the details of that paper in front of me because I've blocked it from my permanent memory because I'm tired of hearing about it, frankly. But you may have it in front of you, I suspect, Elle. So go ahead.
I did refresh it. I'll quickly, just for everyone on the panel and the audience, because this panel is also meant to help people who are committed to trans rights to have tools to be able to respond. And so the Littman paper was, she's an author who who essentially did a web survey to a bunch of anti-transgender blogs for parents who don't want their kids to be trans, and asked them what they thought about their kids being trans. And so I like to analogize that with saying, is going to a meeting of the KKK and asking them what they think about the Black Lives Matter movement, you're not going to get unbiased results. And what she found was that the parents thought their children were rapidly becoming trans because everyone around them was becoming trans. And I just want to point out that this study is flawed. And so when people weaponize it, it's what's the term is selection bias, is when you pick a biased sample. So with that analogy, like if I ask a bunch of racists if they think Black Lives Matters was a good idea, it's the same thing about asking a bunch of trans folks who think being trans is a valid space to be. And so I wanted to address that because I want to sort of demystify the notion that that rapid onset becoming trans is a thing. It's just not how this develops. And if none of the other, and does any of the other panelists want to comment on that, or have I given it enough time?
I did want to quickly speak just before, and it's not going to be long, I promise. It's that these parents believe, our kids are becoming trans because everyone around them wants to be trans. No one wants to be trans. Like, there is so many things that is associated with being trans: increased suicidality, marginalization from in-groups, and just a whole bunch of bad outcomes that people would not choose unless they thought it was integral to their identity while they're here on Earth. And so when I hear things like this, it's just like, why would I choose to be even more marginalized than I already am? Before I became non-binary, I was a Black woman. I feel like that already in itself was an existence burdensome enough, but to add on being non-binary is just something I just wouldn't do willy-nilly just because my friends were doing it. So that is just the only thing that I would add.
Thank you. And that actually segues pretty well into some facts that I want to provide before the next segment of questions. And I really want to hammer home some of the discrimination and bullying that trans individuals, and particularly trans youth, experience. So according to the United States Transgender Survey, which is currently the largest survey of trans individuals, about 28,000 trans folks, nearly 3/4 of trans adults who were out when they were in school reported some form of mistreatment. 1/4 of them were beaten up. 1 in 10 reported being sexually assaulted, and 1 in 6 reported leaving school. And that was and 40% of them had attempted suicide. And that was based on adults who were reporting back on their experiences in school. But to show that these sort of challenges still face us today, the youth risk behavior surveillance study, which is done by the CDC, which is a federal agency, showed that amongst trans youth, 43% reported being bullied on campus and 30% had considered suicide. And so the idea that becoming trans is a fad that people are just aspiring to doesn't really bear fruit when you consider the discriminatory context that living as your authentic self comes with being a trans person. And so with that in mind, I want to talk a little bit about some of these procedures and the elements of transitioning. And specifically, another common criticism is that gender affirming surgery is really mutilation of young children. But can you share to me, Dr. Butler in particular, a little bit about the process of gender affirming surgery? At what age does it occur, and what are the kind of benefits of it? That would be helpful for our audience to hear.
Absolutely. Well, first and foremost, as we've already said, not everyone who identifies as trans or gender diverse is seeking surgery or seeking medical treatment at all. Okay, so we're talking about a small portion of people. So I don't know where this notion of children getting surgery or children getting mutilation, I don't know where that came from, but that just does not happen. It is not a thing.
Thank you.
It doesn't happen, point blank. Similarly, there's no surgery on prepubertal individuals. It doesn't happen. The only time it happens, that you've seen it happen in the past, are on intersex children, and that's usually in the context, thankfully, we're moving away from, for people trying to decide someone's gender for them. So I'm not sure where this whole idea of mutilation comes from, but let's just cut that out right here and right now. As far as gender affirming surgeries go, they are offered in adults. What that looks like in terms of age can vary by state. So for instance, in Oregon, the age of 15 years old is considered to be an adult where you can give consent, surgical consent, without having a parent present. The majority of other states in the United States are 18 years old. There is a really long and rigorous process to getting to the surgical aspect of things. And that can look like chest, that can look like genital, that can look like facial, that can look like body contouring. So there's a lot of different aspects of surgery that we can talk about. But in general, a lot of us rely on the World Professional Association of Transgender Health guidelines to kind of best support how we go forward. So that's typically speaking, patients require at least 1 or 2 letters, depending on the surgery, from either a mental health provider or a social worker in support of their surgery. So documenting that they are mentally sound, they have documented gender dysphoria, and this is really just more out of support for the patient, that they are able to kind of like get themselves safely through surgery. Similarly, it's recommended that patients have been on hormones for at least a year. The idea of whether or not they've been socially transitioned is kind of a nuanced recommendation, because some people don't feel comfortable having been socially transitioned if they don't have surgery. And then, a lot of times we're talking about there's a lot of different, access to care, right? So trying to even get in touch with a surgeon can be really difficult, because here in the Bay Area, we're fortunate, there's a lot of us concentrated in one area. But when you look at, some other areas, perhaps, Dr. Fullerton, like in Georgia, they're few and far between. And then, there's a lot of pre-surgical requirements. So I mostly do gender affirming surgery. So there's usually a hair removal component that can take up to a year for patients to proceed with surgery, in addition to just general health. So patients have to have some stability of housing, social support, financial stability. It's a big undertaking, and we want to make sure that patients can safely get through surgery, as well as, health optimization, diabetes control, and nicotine cessation. So with all that being said, there is a lot that goes into, and a lot of support from a medical and social standpoint that goes into actually someone completing surgery. The benefits are so many. This is, I would consider this a life-saving procedure. There's been multiple documentation of the decrease in mental distress, suicidal ideation for patients who are able to go to completion for gender affirming surgery, for those who feel like they need it. That's within their goals of care. Helps people align their bodies with their true gender identity, so it makes them feel more comfortable in themselves, comfortable in society. And then again, just going back to the genital aspect, it allows patients to decrease their hormone dosage. So, when you remove hormone-producing gonads, ovaries, testicles, it allows us to reduce the hormones that they were previously on, which can be both medically and financially beneficial. So that's that in a nutshell.
Thank you, Dr. Butler. That was wonderful. And just to provide some numbers behind that, a study published in the Journal of the American, the surgical subjournal for the Journal of the American Medical Association, showed that the odds of suicidality decreased by half for people who are allowed to surgically transition. And so that is life-saving. If you can decrease the chances that of suicide amongst this very vulnerable population with gender affirming surgery, it's a life-saving treatment, and we should recognize that. And I do want to state, with no uncertainty, that there are not prepubertal gender affirming surgeries taking place. That is not consistent with the guidelines, and that is not the case.
And not just that, I think it's really important because this gets misrepresented again by the anti-transgender movement. Not only do prepubertal children not get surgical procedures, they don't get medical interventions either. So it's not like pediatricians are out there prescribing hormones to 5-year-olds or 6-year-olds. And while that may seem ridiculous to those of us on this panel, that's what is being promulgated by legislators and by the hate out there. They're spreading misinformation about what pediatricians do, and it's not just about surgical procedures, it's about all the medical interventions.
Thank you, Dr. Garofalo. And that actually again leads us into our next question. It's almost like you guys saw them in advance. But what does transition? Yes, please, Dr. Butler, please.
I just, not to go on a tangent about the politics of everything, but I just want to say, the political movements towards criminalizing things like pubertal suppression only leads to patients requesting and needing more surgery because we're taking away, a less invasive intervention that's leading people to need to go seek surgery. So I'm just saying that they're actually making things worse in a way that people are having to seek more invasive interventions.
And honestly, this was something I was going to get to later, but the blocking pubertal suppression and things that can help transition early is a cruel and awful thing to do. As a trans woman transitioning as an adult, pubertal suppression would have made my life substantially easier, would allow my body, and not to say that transition as an adult is safe, but it's not without risk. My body would have been so much healthier, and my mind would have been a lot healthier too. And that is not because being trans is pathological. It is because the science has moved to a place to make trans people healthy and healthier younger, and political demands and cruelty is preventing the science from doing its job. And I want to say with no uncertainty that it is one of the cruelest things that I, as a Black trans woman, have seen in my lifetime. The idea of taking away life-saving interventions that can make it physically easier for trans people down the line for political gain, because none of this is about protecting children. All of this is about political agendas, and it is awful, and everyone should be ashamed of themselves.
Well, that's the main point. I mean, it's not about children or their families or even healthcare, right? Because it is cruel, but they know better. They know it's not right. I mean, they know exactly what they're doing, but they also know that it's not about children and families or healthcare, right? It's not about that. It's not about these kids. It's not about public health. It's not about science. This is a politicalization of a community to retain power. That's what this is about. It's
because we link trans people to queer people, to gay rights, to liberal agendas, to the binary, the bipartisan movement. And you're just punching at the lowest denominator.
And white gay men are the worst historically, right? I was raised, I said this earlier, I grew up during the heyday of the HIV pandemic, and where it affected mostly Black and brown people. And that's similar today. But one thing was different, right? Our entire community rose up with collective strength and power then, because we knew an injustice was being done to a portion of our community. And the truth is we need that now, right? We can't afford to not have everybody at the table. And so even in my circles, my own social circles, I hear the whispers sometimes, aren't they maybe a little too young? Or should she really be competing as a girl in sports? Sit down. If you can't educate yourself or get better informed, then at least sit down, because there are lives at stake here. And so we can't afford to not have this community unified in the way we were in 1985. The stakes are no different. the lives being put at risk are no different. So that's my soapbox. Sorry.
Thank you, Dr. Garofalo. And just for the interest of time, I was going to ask a question of what transitioning journey looks like for youth and where does it start. But I'll just sort of state what you folks have already alluded to, is that most youth start with social transitioning, going by the name that's most consistent with their gender, going by the pronouns most consistent with their gender, changing how they dress, and a lot of youth, that is sufficient for their transition too. That is where it starts and stops. Some youth need more, and that's what we're about to talk about. But the process does not start with medications or surgeries. And we've already talked about that we don't do surgeries or youth. And those things start later. But social transitioning is the first thing that people do. And it's also the most thing that people around them can help them do supportively. And so with that question, that kind of thrown out there, I do want to talk about pubertal suppression. So that is part of the medical treatment suite of things that trans people can pursue. And so I would like to talk about sort of what there's this idea that all the treatments are irreversible. And so to what degree is that true about pubertal suppression? When do we do pubertal suppression, and what are the sort of side effects? And I'll open this up to anyone, either from experience or from treating patients, but go ahead.
Yeah, so pubertal suppression, I am honestly a big fan of. One, because it is minimally invasive. Two, it buys the child time, so they get time to really explore what gender expression means to them and them only, with the help of an interdisciplinary team if they have the access to get that. And another thing, those two are the big ones, but three, it is very reversible. This is something that is not permanent. If you desire at any time to stop, it is very much so within your power to do that. And so that's why I'm personally a big fan of pubertal blocking. And honestly, puberty in itself is just so violent. It's a barrage of hormones and everything like that. And to be able to have societal support, interdisciplinary support throughout that time, and these are all people that are here for you to try to figure things out, I think it's just a really big help. And so for me, I'm a big fan.
Dr. Garofalo, when do you start thinking about pubertal suppression for gender affirmation for trans youth?
Yeah, I mean, you don't ever prescribe pubertal suppression until someone has at least initiated puberty, right? Again, dispelling that myth that these medications or the medical interventions are used in young children. They aren't. They're used when the prospect of progressing through an undesired puberty is abhorrent to a young person, right? And so imagine if you are in the wrong body and you start developing body parts that are inconsistent with your own self-identity, how disturbing that would be. And so what pubertal suppression is it's like hitting a pause button, right? They're not permanent agents. They bias time. Sometimes the time may be for maturity and behavioral health purposes, to better understand the risks and benefits of gender-affirming hormone treatment. Other times it's to just gain skeletal maturity and other types of physical maturity, so that the medical interventions that we use later might be done more safely or with less untoward side effects. But these are medications that we have used in a number of other populations safely for hundreds of years. Well, I don't want to say hundreds of years because I don't know that that's true. For a very long time, with a significant amount of medical evidence to support their use. And so, again, what I would say is that for a trans-identified young person, because you asked me when do people start thinking about it, they'll often start thinking about it before they initiate puberty, right? Because they're just worried about the onset of puberty and what that might bring. And so there can be a lot of anxiety, or discomfort, or, even depression around just even the thought of having to begin going through sort of an undesired puberty. So that time period, which can really vary by age, depending upon sex assigned at birth, and
Thank you. Dr. Williams or Dr. Butler, is there anything either of you would like to add to this?
No, I think it speaks to the ineptitude of not understanding the science behind it, right? For people who are making these decisions, where, we're really just trying to, delay masculinization of faces for trans females, unwanted body hair, and again, emphasis on these are reversible. We're not trying to make permanent changes. We're trying to help someone get through a really difficult period in their life safely. And it's just extremely lost on today's political agenda, unfortunately.
I just wanted to add something from my own personal experience. So I'm like a late stage millennial, and the hormone blockers the puberty blockers, they were just not something that was available to me. And I really wish they were. Going through puberty was a traumatic experience for me, and as someone who is began transitioning as an adult, I just wish that the resource was available to me sooner.
Yeah, I'm sharing that with you, Dr. Williams. It's something I get extremely emotional about, thinking about my own challenges as an adult transitioner, as also a late millennial, thinking about how much joy I feel on behalf of my more junior trans siblings with the things that are available to them, and then thinking the rage that I feel when I think about the people trying to take them away. Because it's too late for me to have that type of transition that's so much easier, but it's not too late for those youth. And so I just encourage everyone to stand up and make this a community issue. Like cis people, straight people, this is an issue. This is such an injustice. It's a human rights violation. And we all need to recognize that it's a cruelty being done to a vulnerable population of children. The right tries to paint us as people who are abusing children, but really the abuse is by not giving access to this scientifically backed life-saving treatment. And just to hammer home that life-saving element, a recurrent theme you'll hear me saying is providing the statistics. And so there's a 70% decreased odds of suicidality for youth who are given the opportunity for pubertal suppression who are trans. And that's based on a study published in the Pediatrics Journal, which is a high-impact journal in the field of pediatrics. And so again, this is life-saving. And another finding from that study is that it's more common to be successful if you also have parental support. So support from your parents and your community really improves things. Doctor, was there someone trying to add something?
I mean, I can't remember another time when every medical society on earth, mainstream and respected, all agree on the same thing. I mean, we never all agree, right? We're always, the pediatricians never agree with the internist or the surgeons, right? Or the psychologist or the psychiatrist. There's always disagreement. But in this case, the AMA, the APA, the AAP, everybody agrees that this is standard of care. So there should be no controversy here.
Those are the American Medical Association, the American Association of Pediatricians, and the American Psychiatric Association. So those are three of this. And part of it, and you're getting at what I think is the core idea, is that Americans have allowed medical decisions to be completely extricated from the realm of medicine and totally the decision of policy. You see this in the abortion rights discussions as well. And so we really need to bring back evidence and not just our political, religious, and personal beliefs, because the evidence is clear. There is no debate when it comes to the science. It's just that the will isn't that we listen to science, we listen to political grandstanding. I do want to get us on to the next two questions just because to respect everyone's time. And that's sort of talking about the sort of next stage. For anyone, what is gender affirming hormone therapy and what are the potential side effects and benefits for it?
I mean, I can try to answer that very quickly. That's a big question.
Yeah.
Gender affirming hormone therapy is largely either estrogen, a feminizing hormone, or testosterone, and I'm oversimplifying things. It's something that we largely consider in middle to later adolescence or beyond, with consent of parents, with assent of patients, after careful readiness assessments that we can argue their utility or not. But and they allow young people to then progress through a more authentic, pubertal process. They are science based. It's not giving hormones on demand. It's not pushing young people into making decisions about these things. It is, part of standards of care that all of the institutions that I think we are a part of do well in an organized and methodical, careful process, which is focused on both access and quality.
Thank you. Before I ask people to add anything, I also want to talk about there are some open questions and some known side effects, and some of it relates to fertility, and some of it is like the potential cardiovascular challenges that might happen. And so can anyone speak to those two things? And it might be you again, Dr. Garofalo, but and what we do to prevent those things and what we know.
I'll speak at least to the fertility aspect of things because that's at least a little bit what we do. I would say the evidence is not there to fully support, what happens specifically, being on estrogen and anti-androgens with spermatogenesis. We don't know that it's completely irreversible. If you have been unexposed to hormones, there is some evidence that maybe I think it's around 15 to 30% might have regeneration of spermatogenesis. So, the way that folks should be counseled is that if you start hormones, that there is a possibility of you not being able to have a biological child. And so that is something of interest, which a lot of people don't know at that age when they're being started. It's ideal to do it beforehand, but that doesn't mean that you can't after the fact.
And so when you say do beforehand, you're talking about sort of like freezing eggs or saving sperm.
Yes.
And I'll share from my personal experience that for me as a trans person, the option, being informed about that did not change my need. And I say need because it's important for my health to transition. And I'm curious if Dr. Williams, if you want to share your perspective on that as well.
So right before I started hormone replacement therapy, my provider did let me know that there was a potential effect on fertility. But similar to Dr. Lett, I still wanted to pursue hormone replacement therapy because it was just something that was very vital for my survival and happiness. So, and then also, the freezing of eggs is something, unfortunately, is not very accessible to a lot of people. It costs thousands and thousands of dollars. So, yes, there is an effect on fertility, but I have known of many trans men who still desire to actually carry children, and they were able to stop the testosterone and then have children, and everything was fine, even though they didn't freeze their eggs beforehand. And they were able to successfully carry a child to term.
But and I think, go ahead, Dr. Williams.
With me personally, I just knew from a very young age that I never wanted to carry children. So it really wasn't a factor in my decision.
Did anyone else want to add anything to that? One other thing that I'll say is that the reality is that there are some open questions here, and part of the challenges of getting the answers to those questions is because it's hard to fund work in this community because of the politicization of trans health as a scientific discipline. And so if you're concerned, trans people aren't going away. So if your concern is for the safety of us and our fertility and things like that, your best thing to do is to support advocacy for us and to allow this to be studied. So there is like potentially mild, so estrogen is associated with like risks of clotting, and there's potentially mild increased risk of those things amongst people who take that sort of gender informing hormone therapy. But there's been very few studies to definitively demonstrate it. And so a takeaway that I want to sort of hammer home here is that there are fertility options. They need to be covered by insurance to make them accessible, and that it's not true that you are guaranteed to be infertile by gender-informing hormone therapy. And we've had anecdotal and scientific evidence to that just presented on this panel alone.
I mean, I think there are some ethical considerations to be around, like, is it ethical to even ask a young person to make these decisions at 14, 15, and 16? And I think we don't talk about that enough. I mean, they're just realities, right? Decisions have to be made, but I think there are reasonable discussions or debates, to be had, around some of the ethical decision-making process and how that gets done. But again, in a climate where we're just simply trying to fight for the right to provide any sort of access, these nuanced discussions that I think we need to be having somehow get lost.
And I also just want to say that, like, a live child who makes an uninformed choice about fertility is better than one who's not with us.
I mean, there's no question, but that's like a really good ethical discussion.
Exactly. I agree.
Yeah.
I agree that can a child ethically consent, or can a young adult or 15 to 18-year-old ethically consent to not being able to potentially to a decreased risk chance of fertility? And I don't know if that's true, but I don't think the debates that are happening with the anti-transgender movement are about that nuance. I think they're trying to eliminate the option, which is unequivocally in the worst interest of trans folks.
No disagreement.
Yeah, thank you. I want to also talk a little bit in our last few minutes about detransitioners. So a small subset of people who identify as trans may go on to detransition or try to live as their sex assigned, live consistent with the gender associated with the sex they were assigned at birth. And I think this population has been weaponized against trans folks, talking about the regret they might have and having undergone irreversible surgical treatments is wrong because they all regret it. And so I just want to provide a little bit of data around that and then hear your takes on it. So again, the USTS survey, the largest survey of trans people, said that among people who had pursued transition in some form, that includes social transition, all the types of transition, 13% had thought about detransitioning. But most of that was not due to a change in their internal understanding of their gender, but actually due to family or societal discrimination. So being rejected after they transitioned is what drove them back into being the gender they were assigned at birth. And the other thing that I want to talk about is specific regret for gender affirmation surgery. I think this is one of the things that's weaponized so much that they're like, how can you change your genitals, and then what if you regret it? And so of all the trans people in this specific study that was 8,000 trans people, which is a big study for surgical outcomes, only 1% to 2% of trans feminine people had any regret, and less than 1% of trans men had any regret. And this is published in the Journal Plastic and Reconstructive Surgery Journal. And one of the major causes of that regret was actually surgical errors, not related to not wanting to be that gender, but because of just surgical outcomes that were less than ideal. And so when you hear those sort of statistics, what do you think about what it means, the possibility of detransition, and what are the benefits? Is it a good deterrent from transitioning? And also, like, how is this narrative used or misused by the anti-transgender movement?
So I'll address this initially as a surgeon in the room. So I think one thing we need to think about is separating this idea of regret because I want to go back to the gender, or excuse me, the sex that I was before, versus regret because of surgical complications, which you're getting at, Dr. Lett, and recognizing that patients have regret from all surgeries, right? It's not just gender affirming surgery. They just chose to hone in on this one, again, to push a political agenda. There's a long road, as I've already mentioned, for patients to get to surgery. You know, patients wait years, and then have to go through this rigorous gatekeeping process just to even get to it. So this is not something necessarily to be taken lightly. So the fact that they're using it against us as a way to prove why we shouldn't be doing this is just completely erroneous. And I think the numbers speak for themselves, that the levels of regret are extremely, extremely low, and the majority are from family and societal pressures. So I think taking that all into account, I think the concern for regret for gender affirming surgeries is extremely low. That's not something, I mean, it's bound to happen after a number of surgeries, but it's not to the point where it is of concern. We're not pushing this on people.
Yeah, I mean, I guess I would just add from my own personal experience, and I probably easily cared for thousands of trans young people over the course of my career. I'm actually astonished that the number is as high in that journal as 10%, because it's much lower than that in almost any practice that I'm aware of, and almost always, and in fact, in my case, I can only think of 4 young people over the course of my career that truly had regret, and in each case, they happened to be Black trans women from the South Side of Chicago whose lives just didn't fundamentally get better when they began to live their lives as their authentic selves. And what I mean by that is, yes, they might have felt better about themselves internally as they were pursuing their authentic identity, but getting on a bus, going to the grocery store, walking down the street became harder for them, living in terms of daily violence and other issues. And so they ultimately made decisions around self-preservation, not so much about regret around, medical interventions or their gender identity. They made decisions about, like, staying alive and living in the communities that they found themselves living in. And so what I wish for this topic of regret is to be far more nuanced in the way we talk about it, because the lion's share of young people, again, those are the only people that I know that have expressed regret, have really done so from societal pressures, and it has largely been transgender women who, again, as we know, face the overwhelming number of health disparities related to things like interpersonal violence. And so, yeah, those are my thoughts.
And that being said, I'm sorry.
Before you go again, Dr. Bell, I just wanted to say I was actually hoping you would draw that juxtaposition between that data and your clinic, Dr. Garofalo, because that data represents people who are all ages up to 65, and it's like a big sample. And that includes people who transition under a much different era.
Correct.
And so that amount of regret is much lower amongst the youth. And I want to make sure that we recognize that the political climate that we're in risks moving us backwards from the safety that we've gained from transitioning. And so the regret that people feel is not about them being trans. They don't. That's not what the data is telling us. The regret is related to that preservation and that discrimination, and it gets worse based on how people treat trans people. So depoliticizing this and making it about people's health is how we reduce that. Dr.
Right, it's a different form of bias. It's not selection bias. It's like response bias, right? We're selecting or putting them in this box of regret when it's not really. I wouldn't call it regret. It's something else, and it's in many ways something that we should be working with feverishly to make better, because it's about societal reaction to what it means to be trans or to have a trans identity. And so it's not about someone's internal regret about who they are 99% of the time or more.
Dr. Butler, you were going to add something?
Oh, no, that's okay.
Dr. Fullerton, you being a Black non-binary person, how can you speak about sort of that intersection of sort of navigating your trans identity, if you consider non-binary under that umbrella, and your identity as a Black person, and how does that make things more difficult?
So I will say for me, and the idea of passing is a whole other conversation in itself. And so I think as somebody that transitioned to a non-binary identity, but still did not feel the need to have medical intervention or surgical intervention to affirm that, it's just a little bit difficult to have people see you the way you want to be seen. And so having to reiterate every single day, this is who I am and this is who I want to be addressed as, is extremely tiring, because after a while you notice like people aren't looking at you as a person, but you physically. And it is so burdensome when you're actually happy with what you have already, and people do not think that's enough. So when people identify as non-binary, they think that they are owed androgyny from those people, and that is simply not the case. And when people identify as trans, I really want everybody to really understand that you are not owed any kind of passing identity or whatever your idea of passing is. If that person says they are trans and their idea of what they are does not fit your box, that does not really give you the right to devalue that identity. And so that's pretty much what I've been dealing with. And no, I don't think it's right. And we have a lot of work to do.
Could I add something as well?
I was going to ask you next, Dr. Williams. Thank you.
Okay, so I just wanted to add that through like my experience with hormone replacement therapy and gender affirming surgeries, they've just significantly improved the quality of my life. I feel significantly more confident. I feel aligned with my identity. I'm much happier. And the only times I had experienced a feeling of what they're calling regret is largely from the studies have been saying is from external factors. So there have been many times I've frequently been misgendered at work. People who I have had like sexual advances to me as a provider because people perceive me as trans. Let's see, people in many states, people can be fired for being trans. All of these things combined make it, these transphobic forces make it hard for me to live daily. But I still am trans and will continue to use my hormone replacement therapy because it's something that's really important to me. Yeah.
Thank you. We're almost out of time. I just want to wrap up on one final question. And before that, I just want to say thank you both for sharing your stories. And I don't have the need to add anything, but to say that I feel euphoric as a Black trans person when people see me as who I am. And then I've never regretted it, but I do accept challenges with that about passing, about being Black, about all those things. And so I will never regret being trans, but I will feel sorrow that the world hasn't caught up to allowing me to be that way. And with that, I want to wrap up with one of the hot topics right now, which is sports. I think that a lot of the anti-transgender movement sentiments around sports is that it's not fair for trans people to participate in sports of their true gender identity. And particularly, they're talking about trans women competing with cis women, as opposed to, and they don't really have much dialogue around trans men, which is a problem in and of itself. But what do you all say to people who think that trans people shouldn't compete with members of their gender identity?
I'll start with the least sophisticated answer of all, probably. As a pediatrician, it is disturbing to me that winning at all costs seems to be the only benefit that anyone wants to think about in terms of sports participation. For children and for adolescents, we know that participating in sports has a great many benefits, and being able to sort of participate, be part of a peer group is such an important part of affirming many young people's identities. I mean, the only thing I seemed to be able to do well when I was an adolescent was play tennis, and if you had taken that away from me, I'm not sure how my own adolescent development would have been. And so this is an area that I really feel pretty passionate about, because I think the discussion seems to be centered on a very small number of people in a small number of situations, and not thinking about the broader impact, the broader reasons why sports participation is important for all young people and children. The competitive advantage piece, what I wish for this discipline is just to add science to the mix, because I think the discussion being had right now seems to be completely devoid of any actual scientific evidence to support any of its premises. And yeah, I think, again, let's keep our eye on that this is less about sports than just another wedge issue designed to fragment this community, and let's not take the bait.
Yeah, I mean, go ahead.
No, I was just going to quickly add, I think a lot of the buzz around that is that the male sex was put on such a pedestal. I mean, this is going back where they were like the people that went out to hunt for food and things like that. So obviously they would be better at sports, right? And so when you put someone that was born with a male sex that has transitioned into femininity, and you put them in a sport that was with other females that are born with a female sex, it's just giving them an unfair advantage. And to me, that doesn't really exist, because when you train for your sport, you're doing that regardless of anyone else. And so for me, I was an athlete. I played collegiate volleyball. And when I was done with collegiate volleyball and moved into med school and didn't have time for anything else, I did mixed volleyball. So I played with men. And so while I found their offense to be really good, if you were able to fend that off, the defense was not there. So it was really easy, as long as I could pick up their spikes and stuff like that, to move around them and navigate around them, because all they had was power and nothing really else. And so I think that when you look at the issue, it's really just a male versus female issue, and not necessarily this is something that will actually help affirm, and is a big part of social affirmation too, and social transitioning when you look at sports participation. So I agree with Dr. Garofalo. It's like that.
And as far as the science you mentioned, there is very little of it. There is one study on trans men and women who were in the Air Force, and it showed that after a year on cross-sex hormones, trans men were largely caught up to cis men, and trans women had only a started with like a 25 to 31% speed advantage in running and had it declined to like 9% after 2 years on the cross-sex hormones, and everybody was the same for push-ups and sit-ups. And so I think a reasonable way to look at this as far as the science perspective is that it's still an open question that we need to figure out. But right now, we're not making evidence-based decisions. We're making political-based decisions, which is not justice. It's not talking about fairness, if that's what you want to talk about. And also, there are so many people with unfair advantages in sports outside of that. We have height advantages. We have Michael Phelps, who had like just biomechanical advantages. And we encourage that. We allow that. And so we have to think about the ethical rationale for not allowing trans people to also exist in that space. And then the last thing I want to add is that there's no logic for prepubertal segregation, because there's no benefit. There's like prepubertal kids have no differences. They're the same bags of mush, so they should be able to play together.
Well, and who cares if you're prepubertal, whether you win or not at that point? I mean,
exactly.
Come on.
Sports are about navigating social situations, building confidence, decreasing anxiety, physical fitness, learning how to deal with social groups. Like all of those things are, and if we care about kids, if that's what we're trying to say, then we need to think about the benefits for all children. We should care for trans kids too. Is there anything else anyone wants to add on that question?
Yeah, I just wanted to briefly add that their logic for this is often inconsistent because when we look at some of the adult sports, a lot of the times the crowd only really cares when the trans person wins. They don't care when they lose. So that's just, it's not consistent at all. It doesn't make sense.
And to your point, that's about discrimination, not about justice. And so I want to end on thanking you all for being a part of this panel and having a rigorous discussion where we got to talk about some of the evidence supporting trans people and really sort of break down some of those myths and discriminatory narratives that are put up by the anti-transgender movement. I appreciate your allyship and your solidarity, and it was a pleasure speaking with you on this evening.
Thank you so much for inviting me to be part of this. It's good to see you all.
Thank you so much. It was lovely meeting everybody. Good discussion.
Thank you for inviting me as well.
Thank you to our panelists for that much needed discussion and addressing many of the false narratives around gender affirming care. One of the key takeaways I would like everyone to leave with is that gender affirming care is necessary, it's safe, and it is a developmentally appropriate process that occurs in stages under medical supervision for all ages. That means for youth, their parents and their medical professionals are involved. And I also appreciate how the panelists grounded their discussion in science and really emphasized the open questions for further study. Yeah, this is an issue that's obviously bubbling up in a hot topic. But folks who judge and support the anti-trans legislation and policies that have been going on, I believe that they don't necessarily, at least from what I've heard, do not have an argument based in science and an argument that is based in even having experience with actual transgender people and trans individuals. And so there is no harm that is coming to trans youth who are able to socially transition and able to engage in conversations and connect with people that support them and see them and understand who they are and listen to who they are. And there's nothing more dangerous than denying this life-affirming and life-saving care to people, but especially to transgender youth, under the guise of saying that it's irreversible and you're trying to protect them. I believe that this is insidious, and I'm really grateful to our panelists for this conversation. Obviously, I am personally invested in this discussion. Let's move on. So, our day one keynote speaker is Dr. Tonia Poteat. And Dr. Poteat has earned her PhD at Johns Hopkins University in International Health and her MPH in Behavioral Sciences from Rollins School of Public Health, and also trained as a physician assistant at Emory University. She then went on to serve a 2 years in the office of U.S. Global AIDS Coordinator as the senior advisor for key populations. She's now an associate professor of social medicine at the University of North Carolina, Chapel Hill, focusing on the HIV and LGBT health disparities with particular attention to the health and well-being of transgender communities while continuing to practice clinically. Thank you. And here is Dr. Poteat.
Hi, my name is Tonia Poteat. I'm an associate professor in the Department of Social Medicine at the University of North Carolina, and I'm delighted to be taking part in this Black Queer Town Hall in STEM and healthcare. I'd like to talk with you about one of our research studies in my lab called Light Plus. This is a study with Black and Latina trans women living with HIV. And I'll start off talking a little bit about the motivation for this study, a little bit how the study is designed, and some of our early findings. The main motivation for this study was our understanding of health inequities that are faced by transgender people and our desire to better understand them, what causes them, and what we can do about it. So we know that transgender people experience extreme levels of discrimination every day. We know that transgender people experience and report remarkably high levels of psychological distress, especially compared to cisgender people. There is some evidence that transgender people have higher rates of certain cardiovascular or heart conditions. And there's a growing body of evidence that transgender people, and in particular transgender women of color, face an enormous burden of HIV. But we know that these disparities exist. Our question was, what causes some of these disparities? Are the disparities that we see in mental health and heart disease related to the discrimination that people experience? Does this discrimination become embodied? And if so, how? And how can we mitigate, until we can get a more just world and we can prevent discrimination, how can we mitigate its effect on the health of trans people by understanding the relationship between the discrimination and the health outcomes? So we based this research study in the Minority Stress and Resilience Framework, and I'll walk through it pretty quickly. Basically, everyone experiences environmental circumstances that are stressful. However, people who are marginalized and minoritized experience additional stressors. When we're talking about transgender women of color living with HIV, we're talking about people who experience transphobia, racism, ethnocentrism, HIV-related stigma. And these intersecting additional forms of stress are captured in the body and lead to negative health outcomes. One of the ways that we measure how stress is captured in the body is through a measure called allostatic load. And so allostasis refers to the way our body stays in balance. And when we're stressed, it's knocked out of balance. And if we just experience occasional stress, it goes back into balance. But when we experience repeated, constant, intersecting stressors, it's hard for the body to get back into the balance, and that leads to negative physical and mental health outcomes. We didn't want to just stop there, though. We also wanted to understand how people can become resilient. What helps with resilience to mitigate the impact of that allostatic load on people's mental and physical health, particularly coping strategies, social support, and community resources. So our study design was looking at relationships between stigma and stress as it is embodied, relationships between that embodied stress, mental health, and heart disease outcomes, and what is the pathway that connects them, and importantly, how do coping and social support play a role? Can we find evidence for these relationships? And if so, they provide us some information about where and how to intervene. The study is designed to follow people for 2 years, collecting a variety of types of data. In particular, we are looking at survey data to understand people's experiences of discrimination and stress, as well as their reported mental health. We draw some data from medical records. We do clinical measures to look at cardiovascular or heart disease related factors, as well as biomarkers drawn from the blood, and cortisol, which is a stress hormone in the saliva. So we collect a lot of data. We use a lot of this biomarker data to calculate allostatic load. And remember that allostatic load is what gives us a signal about the wear and tear or chronic stress that's held in the body. The way we calculate that is we look at all of these different biomarkers and we see which ones are outside of the normal range. If they're outside the normal range, people get 1 point, and we sum all the points together for the number of biomarkers that are outside the normal range, and that will give us a score that we call the allostatic load index. A higher score on the allostatic load index tells us that there's greater physiological dysregulation or signs of wear and tear from stress on the body. In other studies with other populations, scores of 3 or higher have been found to be high and associated with negative health outcomes. Our study is still ongoing, so I'm going to share with you some of the findings before COVID that gives us a hint of the relationships, of supporting those relationships that we hypothesized in our conceptual model. And then I want to talk a little bit about what we noticed after COVID. So when people enrolled before COVID, we saw evidence that they experienced a great deal of those environmental circumstances that cause stressors, difficulty with educational attainment, high rates of homelessness, and almost every participant reported at least one type of material hardship. And material hardships were things like not being able to pay your bills, not running out of food to eat before the next time you could get access to food, things like that. People also reported moderate levels of discrimination related to their identities and fairly high levels of stress. When we looked at the biomarker data, we saw that this stress was embodied. You can see that in the table on the left that a lot of the biomarkers were outside of the normal range. And you can see that the median allostatic load index score was 4. And remember that a score of 3 or higher is considered high in other studies and associated with negative health outcomes. Then we looked at health outcomes. And when we looked at, again, some of these physical health markers like tests for diabetes, cholesterol, blood pressure, whether people have been diagnosed and treated for these things, we saw a high percentage of our participants who had been, and we saw high reports of mental health challenges like PTSD, depression, and having attempted suicide. When we looked at the relationship between those things, we saw that allostatic load index was, as we thought, related to experiences of material hardship and high levels of perceived stress. We also saw that high allostatic load was associated with lower self-rated health, meaning people describing their own health. And everyone who had an allostatic load that was higher than that median score of 4 had a history of a suicide attempt. So it perfectly predicted a history of suicide attempts. So we can begin to see, even at this early stage with this small number of participants, the relationships that we thought we would see based on our model. Importantly, we also saw high reports of resilience in the face of stressors, high reports of access to social support, and 1 in 5 participants actually reported their health to be excellent. And what we hope to see is an understanding of whether and how these type of resilience factors can help reduce some of the impact of allostatic load on people's health. As we were collecting data, COVID-19 happened, right? And that has definitely been one of the biggest stressors in my lifetime. And we knew it had a big impact on the lives of our study participants. We had to pause data collection for a while, and then we restarted recently, and it provided an opportunity for us to look at what was happening before compared to what was happening after the onset of the pandemic. For this talk, I looked at the data to see how did stress change from before and after the pandemic? How did the pandemic impact people's ability to cope with these stressors? And how did social support and other resilience factors change before and after the pandemic? So no one was surprised to see that that allostatic load index score went up after the pandemic, indicating that there was an increased signs of wear and tear on the body related to stress. I mentioned before that people already before the pandemic demonstrated high rates of resilient coping, and it remained high after the pandemic started. One example of this is a participant during one of the qualitative interviews said, "My self-esteem is so high up there because I went through so much. Now I approve of myself, I'm the only one that has to." So she was able to turn this negative experience into a form of resilience after the pandemic, or after the pandemic started. We also saw that social support went up a little bit after the pandemic too. People reported receiving more social support after the pandemic started. This participant describes one form of social support. She said, it was really hard, but I think what really got me through was friends. I had friends that were walking the walk with me and helped me guide myself. I think also importantly is that material social support. So I mentioned having access to resources as a form of social support. And we saw, not in our data, but in the world, that a lot of trans-led organizations stepped up to provide services that the community wasn't getting from the government and from other social service agencies. Organizations, just a smattering of which are depicted here, provided food, provided small grants, transportation, masks, hand sanitizers, and a variety of other kinds of support for other people in the trans community. We think that that's probably why we also saw rates of community connection go up. So on the top, you can see that before the pandemic, there were already high reports of people feeling connected to the community, and that only got higher afterwards. People responded yes to questions like, I feel part of a community of people who share my gender identity. I feel connected to other people who share my gender identity. And this got stronger after the onset of the pandemic. I also think that this is likely related to pride, to understanding that the community is resilient, has ways of coping and supporting each other during times of crisis, and feeling connected to that. On the left-hand side, you see that the scores on a pride scale related to gender identity went up after the onset of the pandemic. And one participant said, I can now stand in my truth and I know who I am. I don't care what the next person says, as long as I'm happy within myself. And I had to learn that, and I had to be happy within myself. So she was able to find that pride from within. So the story that this data is telling us is that stressors were high for Black and Latino trans women living with HIV even before the pandemic started, that this wear and tear that kind of stress takes on the body only went up after the pandemic started, which is not a surprise to anybody. But I think importantly, participants were able to maintain their resilient coping strategies after the pandemic started. They had increased access to both social and material social support, likely through trans-led organizations that provided that pandemic-related support for them. And that participants reported feeling more connected to other transgender people after the pandemic started. And this may well be related to the increased scores that we saw on gender-related pride. So this was an important story for us, and for us in the lab, it's centered around trans community organizations providing that support for other trans people. And we wanted to see how we could be a part of that. So our next step has been to partner with the Black Trans Advocacy Coalition on a grant application to test the effectiveness of the strategies that they have been using to provide benefit to the community and provide evidence to support the work they're doing so that they can hopefully get more funding to continue doing it. In particular, for this grant, we're looking at micro grants, meaning giving small amounts of money to people over a short period of time, unconditional and does not need to be paid back. And comparing that to giving people these small grants in addition to peer support through peer mentoring. We want to look at overall how that impacts mental health, and we want to see, does it impact mental health by reducing that material hardship that we talked about, increasing connection to community, and reducing psychological distress. So we'll see if that is, if we can demonstrate the effectiveness of these interventions that were designed and led by the community, show how they worked, and support community organizations in getting future funding to continue that work. I'd like to acknowledge and thank all the folks in the lab that help with this data collection and analysis, and the scientific advisory board that helped particularly with understanding some of that allostatic load data that you saw. Thank you so much for listening.
Thank you all so much for joining us on this incredible day. We have our second and last day starting tomorrow at 12 p.m. Eastern. I hope to see you all there. And if you enjoyed what you saw today and want to support, please check out our description and find a link to donate and support Black Queer Town Hall in STEM and healthcare. And share all about what you learned today and let us know. Leave a comment, send us a message or tweet us. Let us know what you want us to talk about tomorrow. I will see you there.